Morning. We are here with our scientific sessions and conference. Yesterday we had wonderful workshop, vaginal surgeries and aorta and Manyata. And today we will begin our sessions. Just to inform you, our scientific chairperson, Dr. Vinita Singh, is not here because of she has lost her father just day before yesterday, and she has sent her apology. And on behalf of her, I welcome you all. Our organizing chair, Dr. Meena Samant and Dr. Amita Sinha will be joining us shortly. So let us begin on time. That is important. So Nikhil is here, who is ready to take my mic away. So all the best, and with blessings of Lord Ganesha and Ma Saraswati, we begin our program now.
Thank you. Ganpati Bappa Moria, and with that we're going to get started with the chairperson. Can I request Dr. Rashmi Prasad to please join us on the stage as a chairperson, along with Dr. Jyoti Gupta and Dr. Bhavna Tiwari ma'am. Can I also request our first speaker, Dr. Kavita Banwal ma'am, to please join us on the stage?
मेरे को दिखाना ही नहीं है.
Yes, ma'am. Please.
Revered chairpersons, seniors, friends. Hearty good morning to all of you. First of all, I would like to thank organizing team POSCON, especially Dr. Ranjana, for giving me opportunity to talk a very less spoken subject, that is how to approach a urogynecologic patient. Menopause actually phase start, a time to bloom, to rediscover ourselves and to enjoy life to the fullest. If a woman is experiencing such symptoms like frequent urination, strong urge to urinate, burning sensation during maturation, loss of bladder bowel control, frequent urinary tract infection, painful intercourse, chronic bladder abdominal pelvic pain, then it is suspected to be a urogynecological problem, and she should be treated by a medical specialist, especially urogynecologist. Pelvic floor disorders are very common, especially in menopausal age group. There are 4 types of pelvic disorders: urinary incontinence most common, voiding difficulties, pelvic organ prolapse, and fecal incontinence. Normally during storage phase, there is relaxation of the detrusor and contraction of the rectus sphincter. While during voiding phase, there is contraction of the detrusor muscle and relaxation of the intrinsic sphincter. And reverse occurs when there is any abnormality. The symptoms can be storage symptoms like frequency, urgency, incontinence, nocturia, or body symptoms like hesitancy, weak stream, straining to void, intermittency, position-dependent voiding, and post-micturition dribbling. So, how to approach to the patient? First of all, we have to take comprehensive medical history, pertinent physical examination, and certain investigations. During history, we have to ask what are the number of episodes leaking, what is the urgency, whether there is any stress incontinence, and what is the frequency of urination both during day and night time, and any body issue history like hesitancy, intermittency, pain during passing urine, use of pads, history suggestive of pelvic organ prolapse, detailed gynecological past obstetric history, medical condition like diabetes mellitus, chronic pulmonary disease, glaucoma, neurological condition, they can lead to incontinence. And any history of surgery or any radiotherapy, and if she is taking excess of bladder irritants like tea, coffee, alcoholic drinks, acidic foods, and excessive drinks. During this age group, there are many comorbidities, and patients might be taking many drugs, so that we have to inquire, like if she is taking any long-acting sedative hypnotics, loop diuretics, anticholinergic agents that have sedative effect, alpha-adrenergic blockers, calcium channel blockers, anti-Parkinson agents like gabapentin, pregabalin. So all this should be asked during history. And thereafter, bladder diary, which is very important in approaching a urogynecologic patient. So at least 3 days bladder diary where we have to ask what is the frequency, what is the urgency, what is the amount of intake, and what is the output. That should be required, and this gives a detail about the complaint and we can approach it. Thereafter, we need to go for examination like BMI should be seen, evaluated for edema, abdominal examination should be done to see the bladder descended, any pelvic mass, tenderness, and then genital examination. When in menopausal group there are signs of urogenital atrophy, escalation of the vulva due to incontinence, cystocele, lactocele, any pelvic mass, and we have to see whether there is any demonstrable leak. Empty supine stress test. When patient is asked to cough and if after body urine, if there is leakage, then positive test and it is diagnostic of general stress incontinence and intrinsic sphincter deficiency. Then after rectal examination should be done to see the sphincter tone, injury, any rectal mass, interosseous. Women with a disruption in a sphincter may have abnormality of the perineal body, that is called lobe tail sign, which suggests defect in the sphincter. Neurological examination should be done to see the mental status, sensory and motor function of both the lower extremities. Sensory dermatomes, we supply the perineum and perineal scale like paternal of H2, H3, and we supply most pubis and upper respect labia minora, that is ilioorgano nerve L1, L2, that we have to see whether she has intact sensory status or not. For that, dermatome maps are useful. And to test motor function, the patient extends and flexes the hip, knee and ankle inwards in the first foot. So most common pelvic disorder is urinary incontinence, which is a significant problem, and there is gross underreporting. Impact are many, like frequent attacks of urinary tract infection, skin breakdown. There can be intense embarrassment, loss of self-esteem, feeling of helplessness, depression, anxiety, work impairment, and it affects quality of the life. So what is the severity index? We have to ask the question like how often she leaks the urine and how much urine she leaks. So depending upon the her statement, we can say like it's 1 to 2 slight, moderate or severe. There are various types of incontinence like stress, urge, mixed, overflow, functional, transient, and there can be certain fistula, especially after surgery and bedwetting in postmenopausal women. Most common type of incontinence is stress incontinence, that is due to hypermobility of the urethra or intrinsic sphincter deficiency. Mostly clinical diagnosis, but routine investigation like urine microscopy culture, CBC blood sugar, kidney function test, and ultrasonography to see the postmortem residual urine. Urodynamic studies are not required, but if there is any mixed lower urinary tract symptoms, obstructive lower urinary tract symptoms, if the patient has undergone any surgery for SOI, if the diagnosis is not clear, and if there is any mismatch between the signs and symptoms of the patient and suspected neurogenic bladder. Mostly fluid management, caffeine reduction, other dietary agents should be prohibited, bowel function should be regularized, weight reduction should be promoted, and smoking, if she is doing it should be skipped. So lifestyle modification is helpful in first stage, and also certain behavioral techniques, especially pelvic floor muscle exercises, biofeedback, bladder control training, they can be of help. Drugs which are given like topical estrogen in postmenopausal women and serotonin uptake inhibitor like duloxetine. Alpha-adrenergic agonists can contract intrinsic sphincter and can be of help. Urethral bulking agents are helpful in first degree of SOI, and newer energy sources like laser and thermobar, they can be of help, mild and moderate SOI. Surgery is required in severe cases like sling procedure, bladder suspension, retroperitoneal corpus suspension, bladder augmentation or neuromodulation. Second common incontinence is urge incontinence, where there is frequency, nocturia, urgency, with or without incontinence. Normally it's also clinical diagnosis, but if there is any hematuria or if we suspect Henne's ulcer, then we can go for cystoscopy. Here management, level 1 conservative measures like pelvic floor muscle training, weight reduction. In level 2 we give anticholinergic agents to calm the detrusor muscle, that is oxybutynin, tolterodine, solifenacin, darifenacin and trospium. Mirabegron is a newer drug, beta-3 agonist that has very good effect on relaxation of the detrusor sphincter. And if it is severe, we can go for botulinum toxin, especially in Henne's types urge incontinence, sacral neuromodulation and percutaneous tibial nerve stimulation. Sometimes women complain mixed incontinence. So we have to judge, if stress is more than urge, then we go for surgery. If urge is more than stress, then we can go for medical management. Second group of pelvic floor disorders is voiding dysfunction that can occur either due to decreased contractility of the detrusor muscle or increased outlet resistance of the urethra. Detrusor underactivity can be due to neurogenic factors like cerebrovascular stroke, multiple sclerosis, tumors to the brain or spinal cord, injury to the spinal cord, disc herniation, transverse myelitis, any type of subsacral pelvic nerve injury, and myogenic factor like acute prolonged bladder distension in menopause, prolonged immobility, recurrent urinary tract infection, after prolonged anesthesia and post-operative, and certain drugs which have relaxation effect and psychological also. And second cause of body dysfunction is bladder outlet section, especially in prolapse, like 2% in grade 1 and 2 cystocele, while 33% in grade 3 and 4 cystocele. Cervical fibroid, ovarian cyst, fecal infection, and anti-incontinence surgery. In that case, there can be about 3 to 15% cases of bladder outlet section. Functional obstruction can occur in dysfunctional body, that is sphincter dysplasia. It is found in young women, Hinman syndrome and Fowler syndrome. It's also clinical diagnosis, urine analysis, culture should be done. Bladder diet is very important to diagnose. Ultrasonography is done to see the residual urine, bladder wall thickness, and to identify any pathologies like stone, diverticula. Uroflowmetry, here the picture is typically prolonged and continuous fluctuating, that is seesaw pattern as compared to bell-shaped pattern. Cystometry measures pressure volume relationship of bladder during filling phase, while pressure flow study measures intravesical pressure during bladder emptying. Electromyograph records electrical potential generated by polyp muscles, and vesicocystogram measures morphology and function of the lower urinary tract. Early recognition of urinary retention after surgery and labor may avoid long-term complications associated with acute prolonged bladder distension. So first of all, if we diagnose, drainage should be done, either clean intermittent catheterization or indwelling catheter. Clean intermittent catheterization is better because it prevents recurrent urinary tract infection. And thereafter, behavioral therapy like lifestyle modification, bladder training, certain drugs which increase bladder contractility like muscarinic receptor agonist bethanacol, or decreasing outflow resistance like cholinesterase inhibitors, distributin, and alpha receptor antagonists like tamsulosin can be of help. Third group of pelvic floor disorders is the pelvic organ prolapse, which is a heterogeneous condition in which weakness of the pelvic floor musculature and connective tissue occurs and results in descent or bulging of the organs into the vaginal canal. There can be associated symptoms related to voiding, defecation, or sexual dysfunction. It's a mostly clinical diagnosis, and examination should be done in standing or dorsal lithotomy position. Levator tone muscle assessment should be done by modified Oxford scale. So nowadays POPQ classification is used, and depending upon the type of prolapse, we can go for surgery, sling operation, or any type of PECSI or hysterectomy. Fourth group of pelvic floor disorder, which is also not discussed much, is fecal incontinence, which is defined as the impaired ability to control passage of stool and gas, or involuntary loss of flatus or mucus. So it's mostly due to pelvic floor weakness or any structural abnormality. We advise pelvic floor muscle exercise, biofeedback, and if there is any abnormality, it should be corrected along with the sacral neuromodulation. So to conclude, pelvic floor dysfunction is very common in menopausal women. Storage and voiding dysfunction can exist together with the pelvic organ prolapse. Advanced age, parity, menopause increase the risk of both the conditions. So it's important to differentiate between the types of the incontinence and other pelvic disorders for proper treatment. All these conditions are diagnosed mostly in clinical settings. Urodynamic study and other invasive tests are required in fewer cases. So our goal should be freedom from incontinence and voiding problem, cure incontinence, keep patient comfortable, prevent discomfort, prevent complications. So menopause is a powerful reminder of a woman's strength and ability to adapt to change. So what to carry message? Good history taking, methodological evaluation, appropriate management, positive attitude, environmental manipulation. With all these, best outcomes are achieved. Thank you for your patient hearing.
Well, pelvic floor dysfunction is the most common complaint. Sometimes patient hesitant to speak within their family members and to discuss with doctors. So you have very nicely elaborated all the points. Thank you.
And with respect to the time, 1 minute पहले भी आपने खत्म किया. You completed 12 minutes. So
आपने जो बोला तो उसको follow किए.
Thank you, ma'am, for this wonderful session. And I would like to ask you that there are some questionnaires that we can share.
Yes.
Do you have such questionnaires which we can share with the patients in our OPDs?
Yeah.
So
yeah.
that
There are questionnaires. I will share in the group.
Sure.
now can I request the chairpersons for the photograph on this backdrop, and we have a memento as well. वो memento is only for the photograph. बाद में वापस रख देना please. Thank you so much. And thank you ma'am for completing it on time. It's also said if you prepared well, you can finish. हाँ ठीक है अभी time count होगा देखो. Thank you so much. Can I request the chairpersons for the next session to please join us on the stage? We have Dr. Aniruddha Poddar, Dr. Rajesh Goswami, Dr. Asha Thakur, Dr. Ananya Agarwal. Can I request the chairpersons to please join us? I believe Dr. Manisha Singh is on the way. Oh, she's here. Dr. Manisha Singh is here and she's going to be our first speaker. Can I request Dr. Manisha Singh to please join us on the stage? Yes, with the permission of the chairpersons, can I request Dr. Manisha ma'am to please start?
So, a very good morning to all of you. At the outset, let me thank the organizers for having me here. Perhaps I'm the odd person out. I'm an oncologist and I don't know how welcome to we are in this group. But anyway, the topic that I have selected is very, very important because we're going to talk about ovarian cancer. Why I said the topic is important? Because if you take the mortality, the death in cancer, it is said that the death of endometrial cancer and cervical cancer together is less than the ovarian cancer. So this is very important. And this is the reason why we are so much focused to talk about ovarian cancer. And you know, it is said that it is a silent growth of ovarian tumor is the rule which makes them so dangerous, because by the time you diagnose an ovarian cancer, it is already very much advanced and then we are really struggling to get to how to get about it. So when I started making my presentation, I thought because the gynecologists are not very much keen to listen on cancer, I'll just take the answers of some of the provoking questions that the gynecologists want to know. So I have just focused on those questions that you all want to know from an oncologist, and this is very important. So my slide is just answering some of the queries that you have, often you fire to an oncologist. So I come to a presentation, there is an abdominal mass floating since 6 months and we got an ultrasound done that shows a complex cystic mass with solid component. CA-125 is 262, not grossly engaged. CT scan shows again 6.5 into 5 centimeter mass. The question here is, are we done? Should we straightaway jump to a diagnosis that I am dealing with a malignant tumor? Is this data sufficient? Because most of the time with this data we jump into to approach a disease. Is CA-125 a surrogate marker that elevated that to 262, absolute, surrogate marker that yes, we are dealing with malignancy? What can be a differential? So, I tell you, the differential for this presentation that I gave you could be 100 differentials. Because we know that ovarian tumor has different parts. There are different tumors originating from the surface epithelium. There can be again a number of tumors originating if the origin is from a germ cell. There could be from the sex cord if the origin is from a sex cord tumor. And don't forget that if you have a deposit in the ovary, just try to find out we can have a primary somewhere else in the GI, and that can be a deposit from a Krukenberg type which we misdiagnosed a cancer. And recently we had a very VVIP patient who was treated for ovarian cancer, but then that was a deposit and she had a primary in the GI. Be very careful when you mark that it is an ovarian cancer. Now, why cancer? Why shouldn't I talk about something which is not a cancer? Perhaps it's a benign disease. So why jump to a cancer? We can have serous cystadenoma. 40% changes into serous adenocarcinoma in due course of time. It can be a borderline. It can be, you can be diagnosed that yes, I'm dealing with a cancer. So when I said that when I gave you a presentation just on an ultrasound or CT scan CA-125, it's very difficult to very clarify that yes, I'm going to deal with a cancer. Do we have any means without getting a biopsy to know whether I'm dealing with a malignancy? Yes, this is something which can give you a hint. This is called a relative malignancy index, where you know that CA-125 can be raised in so many conditions. It can be raised in pregnancy, menstruation, endometriosis, adenomyosis, pelvic inflammatory disease, liver cirrhosis, so many conditions gives rise to CA125. So that's not a surrogate marker. Now, when I calculate a relative malignancy index, what I do, I calculate the CA125 into U. U means what is the ultrasound scoring, that is 0, 1, 2, 3, depending upon your ultrasound finding, multiplied into whether the patient is a premenopausal or a postmenopausal status. In 78% of the time, it will give you a diagnosis whether we are dealing with malignancy with an accuracy of 87%. This is for the PG student, I hardly see them, but yes, you can make something assumption that yes, this could be 87% times correct that yes, I am dealing with a malignancy. We ourselves, when we are dealing with oncology for years and years and years, we get confused because this is about a teratoma. We had deposits in the ovaries where we thought that we are dealing with cancer, but it was not a cancer. So the next question that is being fired to an oncologist, madam, how should we go about? What investigation? What do you recommend? क्या कराना चाहिए? CT scan, MRI, PET, क्या कैसे? The answer is, if you see the guidelines, we have a different sensitivity, specificity and accuracy for CT, MRI and PET. So it all depends what is your intention. If a lady has a family history and she is BRCA positive, I want to screen whether she can develop ovarian cancer, MRI is the treatment of choice. CT in due course, accepted, but when it comes to recurrence, believe me, it has to be PET, and PET scan. I show you the difference why. So this is a beautiful picture of a girl child. Not a girl child, she had mother, nanny and everybody, she suffered from ovarian cancer, they had a BRCA positive, and see how early that could be diagnosed because she was on a regular follow-up as a girl, and when she was in her early 30s, she was diagnosed of an ovarian cancer. So MRI did a beautiful job. But here I show you, MRI just could pick up the small serosal deposit which was very well picked up on the PET scan. And you see the small, intense spots that you can see for a patient who just had a slight rise in CA125. CT and MRI was perfectly all normal. Patient was totally asymptomatic, and she was told that there is CA125, तो ऐसे भी बढ़ जाता है. Don't worry about. But PET scan gave you the answer. So these small intense lesion that you can see on a patient who has a raising CA125 showed you that the patient had a recurrence of the disease. So when it comes to recurrence on a follow-up, be sure that CT scan gives you an extra edge of 60% that you can miss it on routine CT or MRI. PET should be done in those cases. We are doing PET at a very cheap cost. So don't hesitate, because once hesitated, the disease will grow and then you will land up in problem. So PET seems the next valid investigation in patient with a rising CA125. Now what baseline investigation? So majority of the patient, when they come operated, you have to categorize your patient what to be done. This is a very difficult situation for an oncologist. Get it seen by a gynec oncologist, have a family history tested, the hereditary testing, you can have a laparoscopic, you have evaluated disease, sees the disease, and then it's very difficult to make a decision for a patient who has already been operated from outside. Now your decision will depend on what is the age of the patient, hypertension, comorbidities, was the resection done R0, R1, it was an IDS or whether it was a PDS, what was the genomic profile of the patient, what is the phenotyping, what is the histopathology. So a lot of parameters you have to document it before you know what I am going to do with the test. Now, very important, recent advancement is my topic. Please do a genetic testing for all the patients. Why? Because 25% of the patients, they harbor BRCA1 or BRCA2. So why do I only talk about BRCA1 and BRCA2? Genetic mutation beyond BRCA, we have achieved that state. So there are a lot of other genes also that are mutated because they also need to be treated. We have drugs available and we are treating these patients. So when today's prescription, I don't write for BRCA1 and BRCA2, I write HRR, homologous recombinant deficiency, and if that is present, my prescription will change. The drugs have come at a very cheaper rate. Previously, we couldn't afford those drugs, but they have come in thousands of rupees, and all such patient has to be treated. So your prescription has to have the information whether the patient has a germline mutation, yes or no. Why? I'll show you in my near slides. So this is a commercial HRD available at my hospital also, and we are testing for all ovarian cancer, we are testing for an HRR. So if your patient has an HRD positive, the baseline chemotherapy as an NACT, whether we are going to add bevacizumab, yes or no, will depend. And once you have completed your treatment, whether we need to give PARP inhibitors as a drug for maintenance therapy will be decided. So this is a very important recent advancement that now the timeline has changed, that we just complete the treatment and just keep the patient in observation. No, that's not requested. So NACT depends upon what is the germline testing result, depending upon whether we are going to add anti-angiogenic inhibitor, yes or no. Now, I guess we know that all gynecologists, we understand that we have to do a perfect surgery, but what is important is the pathology. So what is the pathology? Why is it important? Because that has to be strictly under the CAP guidelines. So what the information I am going to obtain once I have operated, I have to all the information that the CAP says. And if it's a metastatic disease, not only the histopathological assessment, but also the molecular assessment regarding the assessment of BRAF, KRAS, and so many other factors. So it lists you so many tests that has to be perfectly done to a perfect treatment. Now, again the questions being fired are, can comprehensive staging be performed minimally invasive? So a lot of patients, they ask you, and the answer is, you have the extensive blood loss for laparoscopic surgery much lower than the open surgery. Overall, the upstaging rate is 22.6%. Overall conversion from laparoscopic to open is 3.7%. Overall rate of recurrence is 9.9%. Operative outcome is comparable to LAP. So LAP is no way inferior, but who should be the candidate? Be sure laparoscopic may be an answer only to the person who has early stage disease, high volume center, your doctor being trained to do that. Yes, definitely you are a candidate that you can perform upon. Now the second question is standard surgical staging. We all know what has to be done. The question here is, do we need to address the lymph nodes in ovarian cancer? Does that help you with any advancement or any overall advantage in the terms of progression for your overall survival? This was a line study. I'm not going to the depth of it, but the conclusion was that retrospective analysis suggests that potential OS benefit of the lymphadenectomy without ROS, there was not much difference. So did not improve in the overall survival or the progression-free survival despite removal of the subclinical lymph node metastasis in 56% of the patient. So the answer is not required until and unless you have a visible gross disease. Subclinical lymphadenectomy is no way helpful. Coming to a very important question, HIPEC. This is the hyperthermic intraperitoneal chemotherapy. Now this is the dictum of the choice. So every center where you have the expertise, propose your surgery, please go for HIPEC. HIPEC is, see, this is a picture from my own hospital, and the HIPEC showed that the addition of hyperthermic intraperitoneal chemotherapy resulted in improved progression-free and overall survival. So the team of doctors who are seen here, and they are seen here also because Dr. Podar is sitting, Dr. Ananya is sitting, they are from my hospital, and they have done this HIPEC. So HIPEC is a routine procedure in my hospital. It's not only for ovarian cancer, we're also doing for stomach cancers, we're also doing for GI cancers. So HIPEC is a little costly affair, but because the chemo does not penetrate the IV chemotherapy, so intraperitoneal penetrates, gives you a better outcome, and yes, it's feasible. And in Mahavir cancer, we are doing, and this is the proof of the doctors who are sitting on screen, in my screen also, they're sitting here. So, median overall survival was 33% versus 44.9 in favor of HIPEC. So, definitely HIPEC should be given where it's indicated. Maintenance therapy, once you have completed your treatment, yes, we need to give the maintenance depending upon the germline mutation, BRCA1, BRCA2, NHRR4 that we get. So, yes, the long-term follow-up suggests that if you're giving a maintenance therapy, that is a 46% reduction in the risk of progression or death. So, I'll not take time. The last is immunotherapy. Now, latest, there's an immunotherapy that your body owns immune system is asked to act on your cancer is a very alarming and something very exciting that we have started doing, because the immunotherapy is first we used to do in lung cancer and other cancers, the role has also come in ovarian cancer. I don't have time to tell you the detail, but this is a very interesting thing that the immune therapy that we are grossly using in our hospital. So we have data, papers also in support, And the last slide is, previously we used to panic when we talked about ovarian cancer, and we said that it's something that is coming to an end. But today we have so many drugs available that even if the patient fails to first line, we go with the second, third, fourth and fifth and sixth line, so that we increase the chronicity of the disease. Just like hypertension and just like diabetes mellitus, where you patient on disease, they live long, we are trying to replicate that for ovarian cancer also. So let's not panic ovarian cancer, let's take the specialist advice and let's be happy that at least we can give a good quality, a very long quality of life to even a patient who has a very advanced and a metastatic cancer. So with these words, thank you. I'm sorry for delay, just 1 minute.
Actually, Dr. Sangeeta is not here, she's on the way.
Okay.
We'll have more of Q&A, and if you want, I can give you more 5 minutes.
No. But then she will come and you have to adjust her, so no issues. So thank you so much for patient hearing. Thank you so much.
But as per the schedule also we have discussion time. So if you could have any questions for madam or comments or compliments, all are welcomed.
Dr. Manisha, so what are the patients we're going to advise us for now you said we're not going for BRCA1 and 2, the other test what you mentioned.
HRR includes BRCA1 and 2, ma'am.
And apart from that?
I showed you I showed you that there are a lot of other tests, that is Zentet, 50. They all have a human recombinant deficiency. So all those genes which have a human recombinant deficiency, they act on PARP inhibitors. PARP inhibitors are the drug that has been designed for the patient who were BRCA1 and BRCA2. So previously we used to test BRCA1 and BRCA2, but then other list of genes also which are included in the HRR and which in my center we are exactly costing the same. So if you're testing for BRCA1 and BRCA2, I'll cost you the same, but I'll give you the list of those drugs also. So on the
Which patients?
all patients.
But prophylactically, if we have like
Maintenance therapy for all patients who are HRR positive, HRD.
that is the therapy part. Where are we going to ask the patient to get this test done?
Send it to my hospital.
No,
Or you can send it to any hospital, you can outsource that.
Which ladies, which patient should we send to you for this?
Day one, a lady of ovarian cancer lands into your clinic. Day one, you have taken a laparoscopic biopsy or you have established a diagnosis. You have a chunk biopsy available. You are going to ask for adenocarcinoma or whatever, ask for genetic testing as well. So our prescription says histopathology plus genetic testing. Genetic testing.
That's part of the workup of a cancer diagnosed cancer patients. But what about?
Oh, you are meaning about prophylactic. So I just missed those slides because I was really conscious about my timing.
If you want, we can show it again.
No, but there's reflecting some
एक बार मैडम का presentation वापस लगा दो 2 मिनट.
So that showed that if my I have a strong suspicion of a family history, anybody in my family suspect from cancer. So you all know about the story of Angelina Jolie. She is a very famous actor, and since her mother had a ovarian cancer, her nanny had, so she was such a big star, she got a prophylactic mastectomy done. She got ovarian removed, she had a bilateral sphygmophirectomy, she got an artificial breast, just because she had it running in the family. So definitely those who had running in the family, definitely you got to get tested, but that genetic goes only 10 to 15%. Rest sporadic 80% can have, any one of us can have. So any one of us can be tested for the screening purpose that you say. And the slide what I wanted to really show you that, what is the guideline for such patients? I didn't go in the depth because I thought it will be a time-taking procedure. So the guideline is risk-reducing surgery. So if suppose I'm healthy and hearty and I got tested, I have no complaint. The question is whether should I go for the risk-reducing surgery? What is the guideline does suggest? And yes, this is the risk-reducing surgical salpingo-oophorectomy protocol. If your patient is very keen, the patient has a very strong family history, get it removed, but there is no consensus that you should get it removed. The choice is yours. I will counsel the outcome, but the consensus today is mixed. even if I don't get it removed, I should not be forced to remove, but that does not give me a guarantee that I'll be scared. Perhaps I can have some other tumor harboring anywhere else that I cannot just get the whole body removed. So the consensus is, if you see, the prevention benefit of salpingo-oophorectomy alone are not yet proven. If considered, the fallopian tube from the ephemera to its insertion into the uterus should be removed. In addition, the fallopian tube should be processed and assessed as described above. The concern for this is you will be counseled that you are at risk. If you want to remove, fair enough. If doesn't, be in a regular follow. So this is the guideline. And HIPEC, if you want to ask me, I think my chairperson will be answering you better, because HIPEC we are doing really in our hospital. So this is something very interesting, and we should start practicing, because the peritoneal metastasis is very deadly for ovarian cancer, and that is the reason so many patients dying. And intravenous chemotherapy that we give in a routine way does not penetrate into the peritoneum. So when we give hyperthermic intraperitoneal, that perhaps works in a much better way. So doctor, I think you can make a comment, the chairpersons, what you do in the...
Is there any survival benefit, or is the quality of life that is improved by this HIPEC?
It does provide at least approximately 12 to 24 months of survival benefit. But the main thing is that we should achieve complete resection. There should not be more than one bowel resection anastomosis. So if carefully chosen patients, yes, it does offer survival benefit. Doctor, you want to ask something?
Good morning, ma'am. I just want to ask that what frequently we are supposed to do the PET scan for this patient, the ovarian cancer patients.
So we have a surveillance protocol. So don't do PET scan unnecessarily. If you have a suspicious, a patient is totally asymptomatic and she has a rising CA125 and you're not very sure, get it done, because PET scan has a 60% more capacity to check your metastasis. And secondly, on a routine basis, yearly we do test our patients, but then not necessarily with the PET. So PET has its own indication. You can follow up your patient, and a very high risk patient had a peritoneal disease and it was all sudden disease. Do follow your patient with a PET scan, or whenever you have a strong evidence that the patient can have a recurrence, you can do a PET, but PET is definitely when it's come to a follow-up.
The second question, ma'am, that for an ovarian cancer patient.
Well, just to stop that, because we've got madam.
That the hereditary test is done only for epithelial cancer. Previously it was a recommendation. But it is also given for the germ cell tumor also.
No, we are just talking for epithelial.
Yes, that this is the message that when it is epithelial ovarian cancer, then you have to go for the hereditary or the NGS and all the panel should be done. In the germ cell cancer, it is unnecessary to prescribe this test.
But the baseline you don't know, na? But the baseline test has always have to have your HRR test. Baseline is you have to do that.
Thank you, ma'am.
Yes, thank you so much. We've already got Dr. Sangeeta Pankaj ma'am on the stage. Thank you so much. And I would also like to thank Manisha ma'am for keeping the show running till madam arrives. Thank you so much. Over to you, ma'am.
A very good morning. At the outset, I would like to thank Dr. Amita and Dr. Meena Sawant to give me the opportunity to speak on this prestigious stage. The topic given to me is cervical cancer management, surgical perspectives. I would just like to tell that all the pictures and videos which I have put in, these are all our OT pictures and the original pictures of our OT. So CA cervix, worldwide, it is the most common in women, fourth among all malignancies. It contributes to 6.5% of all cancers. In US, it is third most common, but in India, it is second after breast. And invasive cancer of the cervix is considered a preventable disease. That's why we talk so much about screening and prevention, because it is a preventable disease. And because it has a long pre-invasive stage, and the cytology screening programs are available, and now even vaccines are available which will prevent this cancer in the coming days. And distribution is bimodal, we all know. So according to Globocon, race mortality on the 4th rank, The risk factors are young age, first sexual intercourse less than 16 years, multiple partners, cigarette smoking, high parity, and so on. Symptoms we all know: vaginal bleeding, any abnormal, irregular vaginal bleeding may be accompanied with hematuria, constipation. The signs, we have to be careful because we are habitual of looking at a normal cervix. So if you see something beyond normal cervix, then we have to be suspicious. We have to keep a suspicious mind to get CS cervix in early stages. But sometimes the patient will complain that I am having irregular bleeding, but the cervix will be looking normal. So that time again you have to think that maybe the transformation zone is inside. So you just look for an entrance cervical root. And per vaginal and rectal examination is must for clinical diagnosis in patients of cervical cancer to detect the parametrial uterosacral side walls. That if there is parametrial invasion, because our management will depend on clinical and imaging studies. Because in cervix we are more dependent on clinical imaging. So according to NCCN guidelines, workup has to be done, history, physical examination, CBC, LFT, KFT, as we do in all cases, if suspicious, bone biopsy. And approach, how to approach for it. If you see some obvious lesion, then you can take punch biopsy or leave. But lesions are absent. You are not able to see. Get a pap smear done, HPV done, and HPV is positive. Even pap smear negative, symptoms are there, get a colposcopy done, and accordingly you have to manage. CT and MRI is more specific. So we prefer MRI, PET CT, definitely more, but due to cost constraints, we don't go for it. The new figure staging 2018, it is almost the same, only in 1B there are some changes and 3C, because they have included lymph node extension. If it is, the tumor size is small and the lymph node is positive, then the patient will be upstage to 3C depending on pathology or radiology. So the management, now we have to do either surgery or radiotherapy. Advantages of surgery are, in young patients you can preserve the ovary and the side effects of radiation will be less and sexual dysfunction will be less likely. So management has to be done by the stage. In early stages for surgery, in advanced stages including 1B3, we send the patient for radiotherapy. So what is the benefit of upfront surgery in early stages? And nowadays many trials are coming, safe, conservative. We say that we should go for more conservative surgeries. So in early stage 1A1 and 2, diagnosis will be mostly on leaf when you are on a trachelectomy. Lymph node will not be present many times, but if there is LVSI, we have to manage accordingly. So if 1A1 with no LVSI, you ask your pathologist, kindly mention LVSI, even if it is on leaf or bone biopsy or any sample. If on bone biopsy margins are negative, we can follow up. If the margins are negative and operable, we can go for extrafacial hysterectomy. If the patient has completed a family and positive margins, then we have to manage. Positive margins and LVSI, we have to go for radical hysterectomy. So modified radical in LVSI positive and 1A2. And there is risk of lymph node metastasis in 3 to 8% cases. So we do lymph node dissection in these cases. Stage 1B1, this is low risk, again modified radical hysterectomy. In 1B1, 1B2 and 1A, we can go for radical hysterectomy with pelvic lymph node dissection and para-aortic lymph node sampling, I would say. And 1B3 and 2A2, radical hysterectomy, and they will need primary chemo radiation also. Fertility sparing surgery can be done in early stages. Cervical cancer does not spread to the ovaries. So in young patient, we should try to preserve the ovaries. And in post-treatment follow-up, general examination, every 3 months you have to follow up, and at least it has to be followed up to 5 years, and then accordingly the screening schedule has to be followed. This is the colonization. This picture is not mine. Colonization can be done in stage A1A with no LVSI, And the process, I think many one of us have done this conization, vaginal preparation with stage 2 sutures. Identification of squamo-columnar junction is very important, and then we give circumferential incision starting from 6 o'clock, and then tag the specimen and send for biopsy. Radical tracheotomy can be done in fertility preserving surgery in some patients, and for stage 1A2 and 1B2 lesion, 1B1 lesions also if they are less than 2 centimeters. And abdominal approach is much better because we are more habitual of doing radical hysterectomies, so it will be easy for us to do. By abdominal approach, larger resection of parametrium can be taken than vaginal approach, and it is easily done, and it can be considered up to larger tumors also. So I will not go to detail in this, but following radical tracheotomy, women will continue to menstruate. This is the advantage, and when we do cesarean section, a classical incision is recommended. So this is abdominal tracheotomy and simple tracheotomy. This will be the specimen. When we compare simple tracheotomy to radical tracheotomy, it can be done in situ and stage 1A1 also, and radical can be done up to selected patients of stage 1B2. So vaginal tracheotomy I have not done till now, and it is very difficult to get the patients because unless we have a very suspicious mind, we will not get these patients in early and young patients, even in pregnancy patients. Because cervical cancer in pregnancy is the most cancer pregnancy. So we are not habituated to do per speculum examination. We think that pregnancy will be disturbed. But it is very strange to know that this is the most common cancer. So at least you should have a one per speculum examination of the cervix, even in pregnancy. So these are the book pictures of vaginal cuff preparation, of vaginal tracheotomy preparation, and enter the vesico-uterine space, paravesical space, and bladder pillars, excisional pillars, parametrium, and the important thing is that you have to leave the vascularization of uterus and to preserve the fertility. Then transection of the cervix, placing the surplus, and the new cervix will be formed. Hysterectomy types, there are different hysterectomy types, but we are more concerned about the modified radical hysterectomy because nowadays we are doing, so this I will be speaking in. This was the Weimar times. It was, this is the normal hysterectomy we do, extrafascial hysterectomy, and the modified Wertheim's hysterectomy, which is after his name. This is the area which we remove. So the difference for the radical hysterectomy, which was done before, is that the uterine artery has to be transected at the level of crossing of ureter, and the cardinal ligaments are not divided near the side walls, but instead it is to be divided near the mid portion of the ureteral dissection, and the anterior vesicouterine ligament is divided, but the posterior vesicouterine ligament is conserved. And smaller margin of vagina is removed. You can remove vagina as much as you can. On per speculum examination, you see what is the lesion, and then you can remove the vagina accordingly. So when you open the abdomen, a proper abdominal exploration has to be done. Explore the peritoneal cavities or the enlarged lymph nodes, metastatic deposits under surface of diaphragm. Everyone you have to just explore. Then you start, after you exploring, you just see the bladder, whether it is it can be mobilized or not. Either it can be first step, or you can go to the round ligaments. We start from the round ligaments, and round ligament has to cut as far as possible to the abdominal wall, and the infundibulopelvic pelvic ligaments also has to be cut as far as above the crossing of ureter. And then we develop the spaces. The different spaces, the bilateral spaces are the pararectal space and paravaginal space. The unilateral spaces are the prevesical, rectovaginal and retrocecal space. These spaces will help to more better dissection of the nerves and the parametrium. The paravesical space is opened from anteriorly from the broad ligament, and this is the internal iliac artery, this is uterine artery, and this is the parasubvesical space, and this is the pararectal space, and this is the uterine artery. And the ureter has to be isolated. It is better to track the ureter from the bifurcation of the common iliac arteries. And then you can try, you can just go dissect and you can just have the avascular spaces. No bleeding will happen. Then you have to divide the uterine arteries, you have to identify the uterine arteries. It is just a simple step. When you just open the broad ligament, if after 3-4 cases you will easily identify the uterine artery. This is a small video. हम कर रहे हैं आपको चाहिए Just identify the uterine artery. It is very easy, and you dilate it in 2 places, and then you can cut it in between. Then the urething of the ureter has to be done, and then I have few videos of the surgeries.
So we will see the video, we'll have no question and answers. Is that okay?
This is the ureter, you just track the ureter, and urething has to be done. This is the opening of the uterine tunnel. We know the water flows below the uterine arteries. So the uterine artery is above and the ureter is going down. So you just have to open the tunnel. So posterior dissection has to be done. This is the picture after lymph node dissection. All the uterus removed. Nerves and all the arteries can be seen. I've just shown you. The base has to be retracted. We don't have to injure the obturator nerve. But if sometimes the obturator nerve has been cut, you don't worry, just repair it with Prodil 50.
Sorry, ma'am, our time is up. If you could help us conclude and give us the closing remarks.
So when we do laparoscopic for surgery for this minimal invasive surgery for CS cervix early stages, it is very easy, and even the residents they can all see, and even we are able to make out all the structures very nicely. This is the video after the radical node dissection. You can just see how nicely you can just identify all the structures. And even when you are doing open, but in open surgery there is a little more of bleeding. So you can identify all the structures and all the vessels has to be made naked.
I'm really sorry now, but we will have to cut down. But madam is available for a tea or a cup of coffee, and she can.
So para dissection we generally do. Rather, if it is positive, we don't do the surgery. And vaginal closure can be done by Vital. As we all do, this is the specimen after the radical hysterectomy. You can see the vagina. You can remove vagina as much as you want, and the lymph nodes at least 25 to 30 you can remove very easily.
Thank you so much. With that, can I request the chairpersons and the speakers to please join us for a photograph with their closing remarks?
I would just make a concluding remark, ma'am. That was a very nice talk.
Actually, I had more videos of it.
Yeah, gynae onco Endometrium and ovary were always controversial. Now even cervix treatment has become controversial, and people saying that we need not do such extensive surgery.
Actually, trial, shape trial, conserve trial, or that trial, all the trials I had the slides. So everyone is saying that we have to go for more conservative surgery in early stages of cancer. But we have to make just individualize the patient, which patient we have what surgery we have to. After the SAFE trial in ASCO 2023, everyone is going for more conservative surgeries. Yes.
Thank you.
Thank you so much. Yes, with that, can I request the chairpersons for the next session to please join us? We have Dr. Usha Tidwania ma'am. Can I request Dr. Chuchitra Chaudhary, Dr. Himali Sinha and Dr. Monica Anand to please join us on the chair? Can I also request the first speaker, Dr. Pratibha Singh, to please join us? With the permissions of the chairpersons, can Dr. Pratibha start? Because वो मुझसे कह रही है कि समय थोड़ा सा ज़्यादा दो. So can you, please, yeah, you can start, madam. Please go ahead.
So, can I start? Yes. Okay. So, respected chairpersons and my dear friends, a very good morning to all of you. Once again, I would like to thank you all for giving me this opportunity. And today I have been asked to talk on predictive and early intervention of a very unpredictable disorder, that is gestational hypertension. Now, pregnancy-induced hypertension is reported to be a global problem, complicating around 10 to 17% of pregnancies. And preeclampsia is a multifactorial pregnancy-related disorder which is characterized by hypertension and proteinuria after 20 weeks of gestation. And it is the second most common medical disorder during pregnancy, and it is one of the most common disorders associated with the increased risk of maternal and fetal complications. Therefore, early detection and prompt treatment may result in favorable prognosis for both mother and fetus. Preeclampsia is mainly responsible for large maternal and fetal mortality, and till date, preeclampsia still lacks a safe and effective therapy as well as reliable early means of diagnosis or prediction. Although universal screening is recommended, but there is no single effective screening test available. Thus, assessment of the clinical risk factors helps us to more vigilant. And for that, because the rate of preeclampsia depends on severity of underlying complications and combination of risk factors. And here the risk factors mainly can come from the screening by maternal history, and the most important being the family history of preeclampsia, first pregnancy, then pregnancy before 20 or 40 years, increased interval between pregnancy, obesity, multi-fetal gestation, history of medical disorder like diabetes mellitus, kidney disorders, or rheumatoid arthritis, and smoking. Now, pathogenesis I will not be including because we have a talk after this. But few things I just want to tell, that in a normal pregnancy, an important factor is properly functioning of the blood vessel, blood flow through the placenta. And for that, there is invasion of the placental trophoblast, so the uterine spiral arteries are rebuilt, and this will widen and reduces the resistance, so there will be good perfusion. But when preeclampsia occurs, these arteries are not completely remodeled, and this results into insufficient perfusion in the placenta. And this results into release of numerous biochemical factors in the pregnant women's bloodstream that influences endothelial dysfunction, stimulation of the mother's immune response, oxidative stress, and activation of the coagulation pathways. And these changes will lead to hypertension, proteinuria, and dysfunction of the internal organs. So, these biochemical markers are very important for prediction, but what should be the ideal biochemical marker?
It should be the one which plays a central role in pathogenesis, be specific for the condition, should appear or before so that before the clinical manifestation occur. It should be cheap and easy to detect in maternal blood and urine and should show high sensitivity and specificity, and it should correlate with the severity of the condition. And very importantly, it should not be detected or it should be in a very low level in a normal pregnancy, otherwise it will cause confusion. So in 2004, WHO came up with this test for prediction of PIH, which included mean arterial blood pressure, rollover test, Doppler ultrasound, isometric exercise test, and so on and so forth. But 24 hours ambulatory blood pressure monitoring was very important, and still blood pressure remains the cornerstone of early diagnosis. Although it has many limitations like measurement errors associated with this sphygmomanometer, effect of the maternal posture on BP in pregnant women. And if you see, mean arterial pressure is a better predictor of preeclampsia rather than systolic and the diastolic blood pressure. And in second trimester, its cutoff is equal to or more than 90 millimeters of mercury. These are the biomarkers which are specific for fetal-placental unit dysfunction, and these are for renal dysfunctions. Now, hyperuricemia, which we see is usually the early signs of renal involvement, and it correlates with the clinical severity and the prenatal outcome. But despite of good amount of studies, not all studies suggest that the serum uric acid level may begin to rise before the onset of hypertension and proteinuria, so not always it can be used as a predictive marker. These are the other markers for endothelial and the oxidant stress dysfunctions, and these are the novel urinary markers which can detect pregnancy at early stage. So I will be taking few of them which are important. In spite of so many markers in the market and so many advancement in this, still a careful history taken early in the first trimester can warrant attention for effective prediction and prevention towards mothers at risk. Now, we are really proud that we have our own Foxy Engine developed this HDP gastrosis score, which is a simple risk model score which we all can download on, and it is an app which is available everywhere, and that can be downloaded in your mobile and can be used in all patients. It is a primary clinical assessment for screening and prediction of preeclampsia, and the scores are 1, 2, 3, which are allotted to each clinical risk factor as per the severity. And if the total score is more than or equal to 3, then the pregnant woman should be marked as at risk for preeclampsia. This is multifactorial model which include beta HCG, maternal age, BMI and parity. Again, sensitivity of almost 70% and specificity for 71%. Now, inhibin A is also a sensitive marker, better than HCG. Then pregnancy associated plasma protein A. This is 1628 amino acid protease, mainly produced by placental trophoblast. And in fetus with normal chromosome decrease, the decreased level of PAPA in first trimester is associated with increased level of early onset of preeclampsia, IUGR, small for gestational age and preterm delivery. And when it is used as a single biomarker, its sensitivity is only 20%, but if it is used in combination with Doppler, then its prediction rate is as high as 70%. Now, placenta protein 13, it is again a member of galectin family protein produced by placental tissue, and its level gradually increases in normal pregnancy. So, decreased level in first trimester in pregnancy is those patients will develop preeclampsia. So, abnormally low levels of PP13 were found in the women who developed preeclampsia, IUGR and preterm delivery during second and third trimester. So it was concluded that PP13 is reasonably biochemical marker for early onset and preterm preeclampsia, but a weak marker for preterm at term, and its prediction rate raises to almost 71% when it is combined with doctoral studies. Now, fetal hemoglobin and alpha-1 microglobulin both are involved in the pathogenesis of preeclampsia, and they are the early markers around 10 weeks of gestation, and it is a very simple way of detecting it by basic ELISA test, which has a high prediction rate. Then now we have seen that many researchers, they have found that these genes are also responsible for preeclampsia. So this is the US researchers from Washington University School of Medicine in St. Louis. They have analyzed DNA for over 300 pregnant women, out of which 400 had a normal pregnancy, whereas remaining 250 were being monitored for other health complications. And what they found that the 40 of these were also, they went into preeclampsia. And they found that out of these 40, there were few who had a normal pregnancy also. So DNA analysis revealed a few genetic errors which were shared by 5 of the 60 otherwise healthy women and 7 of the 40 high-risk pregnancy. And the gene which were identified, they were MCP factor 1 and factor H, which plays a role in regulating immune response. And the researchers believe that this could explain the possible link of preeclampsia with lupus and other certain autoimmune diseases. So with this gene, you can identify at least 10 to 15% of preeclamptic patients. So it is also important now because it allows us to study new treatment to prevent or delay the onset of preeclampsia and to know that which women need closer surveillance. Now this soluble hemoglobin, again, it is a second trimester marker for preeclampsia, and the level was found to increase in 2 to 3 months prior to the onset of severe preeclampsia. Then soluble FTL1, that is FMS, like tyrosine kinase receptor 1. This is an anti-angiogenic soluble from the form of type 1 vascular endothelial growth factor receptor. Now its elevated level is associated with the onset of preeclampsia and severity of disease, which usually occur prior to almost 5 to 6 weeks before the onset of symptoms. And this is a very good marker, and if you see the ratio between SFFT and this placental growth factor, the level, if it is more than 85%, then it shows that the women who are, these women are expected to develop preeclampsia symptoms and possible complication within 1 week. So immediately you should admit this patient and treatment should be started. But if the level is between 38 to 84, then this would indicate that these women have an increased risk but will not develop preeclampsia within 4 weeks. So follow-up is required within 1 week. And if it is less than 38, then these women are likely to develop preeclampsia and its complication within 4 weeks. So follow-up should be after 4 weeks. So these are the first trimester screening markers, and if it is associated with if it is combined with doctor studies, then it gives a predictive rate of as high as 77.8%. Lectin is a product of, it is also produced by growth cell and the placenta, and it mainly affects the number of processes including angiogenesis, growth, and immunomodulation. It is involved in the pathogenesis of preeclampsia, and the studies have shown the high maternal lectin levels in the second trimester of the pregnancy is present in the women who have preeclampsia. Doppler studies, you all know, is very important, and mainly the umbilical and uterine artery studies, and the association with preeclampsia include high umbilical artery resistance waveform, notching of the uterine artery waveform in the second trimester, and increased impedance of the flow in the uterine artery, and oligohydramnios. So this all gives the increased risk of development of preeclampsia as well as IUGR. So these are the nutshell all biomarkers which are responsible for, which can predict preeclampsia at the early stage. But in spite of all these, there is no proven effective method for prevention of preeclampsia. We can either go for a primary prevention as she does not conceive, like use contraception, secondary by aspirin or calcium supplementation, and tertiary by antihypertensive drugs, magnesium sulfate and antioxidants. So combined treatment can be used in the form of pharmacological prophylaxis, nutritional supplements, lifestyle intervention and diet. Now Roro has explained, I don't need to explain because he's standing here, I have to finish fast. So this everybody knows that this gives this can be prevent preeclampsia and should be started at least 16 weeks prior to the 16 weeks of gestation. Calcium supplement, again, high doses of calcium can be given, that is 1.5 to 2 gram per day, which is found to be protective in population who has a low baseline calcium intake. Lycopene, again, it is very important because lycopene is an antioxidant which is effective in reducing preeclampsia, IUGR, as well as blood pressure. So there are a lot of studies on that because it mainly inhibits oxidative stress. And this is the evidence which has come from our own Dr. J.B. Sharma, who have conducted this study where they have given 4 milligram of lycopene, and he found that this could result into reducing PIH, that is preeclampsia, by 51% and IUGR by 49%. Nitric oxide, again, it is a good antioxidant. With L-arginine, it causes relaxation or vasodilatation, so it is a very good preventive measure. Again, branch chain amino acid also is very important, which can encourage placental and fetal perfusion. So these are the nutritional supplements which can be used for prevention. So with this, I just want to conclude saying that preeclampsia is still a dominant problem in third world, where it is first diagnosed when the women present with eclamptic seizure. This is very common scenario in our country. Screening of Down syndrome in first trimester is a good example where a combination of ultrasound scanning and blood biochemical markers can be used. Till then, potential first trimester biochemical markers are PAPE, fetal hemoglobin, and AIM, and which can be measured by basic ELISA technique and has a high prediction rate. Other biomarkers are these FLT1 and prostaglandin and the placental growth factors. Although they are not useful in first trimester, but from second trimester they are very much useful. Also, PP13 have shown potential as a biochemical marker for early onset of preeclampsia if it is combined with Doppler studies. So, but in spite of this, as a general screening marker for all types of preeclampsia, the data is conflicting and needs further investigation. So we should always try to welcome a new important, all the new factors which are coming, because instead of this, we should welcome all the new important puzzles which pieces that can contribute to illuminating the etiology of the preeclampsia. Because still, in spite of so many advances, we hopefully lead to a better prophylactic treatment, reducing maternal and fetal morbidity, because preeclampsia can never be totally predictable, and better prediction will help to focus on antenatal care more effectively. So I just end by quoting two knowledge messages, that is, to know is to know that you know nothing. That is the meaning of true knowledge. When you know something, to hold that you know it, and when you don't know something, to allow that you don't know it, that is knowledge. Thank you so much for patient hearing, and thank you for giving me a little extra time.
Thank you so much. Can we have our next speaker, Dr. Archana Verma? Yes.
That was a very exhaustive talk, Dr. Pratibha, almost reminding me of a PG lecture. But I just want to say one thing, that it's very important to measure blood pressure properly. And it will be very surprising for you to know that the toughest question I used to ask the postgraduate was writing down the steps of blood pressure measurement, and that was almost like a torpedo.
Yes.
And the other thing is the gestosis score. That is very good. It's all clinical based. So if we concentrate on these two things, those tests, I have nothing against them, but they cannot be used everywhere. Especially in our setup.
Yes.
Thank you.
Thank you. With that, we have our next speaker, Dr. Archana Verma, ma'am. And everybody is asking, why did I give more time to madam? Is because our third speaker is not there. So, second is there. Thoda sa. But we're going to have inauguration, so madam bhi jaldi khatam karenge. Thank you, ma'am. Can you please start with the permissions of the chairperson? Yes, please.
पहले मैं चेयरपर्सन को नमस्कार time. Namaskar. So.
Let me introduce Dr. Archana Verma. She is past Vice President Foxy, founder, President, West UP chapter of ISOPAB, past Chairperson Public Awareness Committee Foxy, and past President Ghaziabad Ops Gynae Society, India Book of Award winner, Dheera Foxy Award winner, and we also V for Stree Award winner. So congratulations and welcome on the dais.
Thank you, madam. With respect to all the chairpersons and all the seniors and respected teachers, I must say coming to Patna is a big thing. It's एक होता है ना गुरु भूमि है यहाँ तो सब एक लाइन से हैं तो I'm little nervous also speaking in front of like a teacher sitting here. Dr. Alka Pandey is there and one of my best friend who is heading the Patna Society, Dr. Meena Samant. So I must want to congratulate like things and all the talk should be like that. The previous speakers were wonderful. I was listening and that especially Dr. Manisha Singh, I want to congratulate. What a wonderful talk it was. And this Dr. Meena Samant has made this continuity like prevention, prediction, and then my talk on zero eclampsia, and then after that tertiary care. So you know, because we all are talking about the women wellness, we all want to save our mothers, and we are always afraid of this thing that this is want to say that zero eclampsia mission is what preventing the eclampsia number 1 and number 2 preventing the eclamptic deaths. So in this in India, you know, pregnancy itself is a high risk factor, and JAPA mein jaan hi jaani hai. That way patients are afraid also, and doctors also they're thinking, because the 15% of the high risk cases in obstetric antenatal care, we always triage the patient, and when we write the high risk pregnancy, the patient always asks, what do you mean by madam, what is high risk? Am I at risk, or at my family is at risk, or my baby is at risk? And somehow when you know the baby risk is always there along with the maternal risk, and this is the scenario in India. Though we are doing very good work and we are saying that we are reducing the maternal mortality, but the thing is this, the hypertensive disorders still are on top after the hemorrhage. And this is a picture, you know, beautiful picture, antenatal period, and that first time the big the things started with the good news. When the patient see that simple urine pregnancy test, that she is very happy, her family is very happy, and they are all into a divine bliss. And then something if happens, if somehow we lose a patient, then when a woman dies as a result of her pregnancy, it not only affects her family and also the community, and so also the nation. And you know why we always compare ourselves with the sometimes we feel upset that that developed countries are doing so good and we are quite far behind. But sometimes, you know, in May 23 you must have heard the case of Tori Bovai, who was an athlete, Olympic athlete, who won 3 medals, and she died of eclampsia at 7 months of pregnancy. So that means this eclampsia can occur to anything, anybody, and this but to make the pregnancy delivery safest, they have done wonderful work, and because of their drills and toolkits, and best is the team readiness. So primary centers and then tertiary center, that continuum of the care is so much important over there, and they are the leaders who have made this documented, and the critical care in obstetrics. Abhasina madam if is here, then namaskar madam, Dr. Usha Sharma madam. So this critical care in obstetrics is very, very important to understand, because those gone are the days when patient used to come and हमको तो सिर्फ delivery कराई अब चले गए, but nowadays in PPH also we say each and every patient is a risk for PPH. So so is the eclampsia. So and there they have to give those points, and they are doing unless and until like we are afraid ki once we did MD and after 10 years we think we are professors, then they are good. All the medical college, they are always teaching, they are always in touch, but somehow then private practice there are CPD programs type of thing is needed. So our goal, we should know our goal. So my talk is mainly on the goal and the mission, what we want, this anemia Mukt Bharat. We are following that only, cancer Mukt Bharat and this eclampsia Mukt Bharat. So this eclampsia, I want to ask even the chairpersons and everybody, do you think that this you can prevent getting the eclampsia patient? How many of us are getting eclampsia in our practice? I think it has been reduced a lot, and we can reduce the eclampsia rate, though we cannot predict, though we cannot prevent the pre-eclampsia, but if we are aware, if we are looking for, we can definitely prevent the eclampsia, and we will be talking about that. So preventing the eclamptic death and any maternal death, so this solution was given by the government of India about the 100% institutional delivery, and our aim is to reduce the MMR globally to by the end of the 2030. That this is called SDG goal, to reduce it up to the 70. So if we are aware of our mission, we are contributing to this goal. So there are two goals. Number one, eclampsia. We want to get rid of eclampsia, and we want to reduce to zero the eclampsia mortality. So can we, because like previous speaker Dr. Pratibha Singh said, in India, there is a lot of increasing you are hearing obesity, NCD, diabetes, and everything. They are all contributors to age. They are all contributors to the risk in the pregnancy. So it seems that it is very difficult, but no, if we work, then eclampsia is 100% preventable. Madam, do we agree? Madam that chairperson has said. Usha madam says no. So 100% nahi hai ma'am, 99%? 95%. Okay, done. So the house says it is not 100%, 95%, and 60% mission is already done by all the top gynecologists of Patna, and maybe 80 and maybe 95 is there, but our aim is to go to the 100. So 100 may not be look difficult, but yes, if we really look into this, if we detect pre-eclampsia, eclampsia, then this thing, our work is half done, because the mortality ये जो स्टार्ट है ना, जैसे तब तक बाढ़ आएगी ही नहीं जब तक बादल नहीं आएंगे और बारिश नहीं होगी, तो वो स्टार्ट में ही अगर आपने थोड़ा केयर किया तो आप उस तक तो ज़रूर उसका इतना कर पाएंगे. एंड एक्लेम्सिया का 2% रेट है मोर्टालिटी का, इंसिडेंस का, बट समहाउ व्हेन वी कंपेयर इट टू द नॉर्मल पेशेंट में क्या उसका चांस है इसके कि सीवियर हाइपरटेंशन में, सीवियर एक्लेम्सिया में कितना चांस है, तो सीवियर एक्लेम्सिया में चांसेस ऑफ मोर्टालिटी आर मच मोर. So why we are still behind in India? Why that 5% is also not there? Maybe I am saying just maybe. I'm respect to, and just pardon me if I hurt anybody, but no, it is actually no, that why there is that substandard care, the respect and adherence to guideline. हम नहीं सुनते, हमारा तो अपना ही है, हमने बहुत अच्छा कर रहे हैं. It is generally not, we are not following maybe we are not following the guidelines, and there is absent training modules also, and bad attitude of the training, going to the training also, time ही नहीं है. भाई हमें अपना पेशेंट देखना है, आज हमारे सिजेरियन लगा हुआ है, आज हम क्यों ड्रिल में जाएं, हमको तो सब आता है. एंड नो कंसेप्ट ऑफ टीम वर्क ऑल्सो, एंड जितना भी नेबर है, जितना भी पड़ोस, सपोज गाजियाबाद में अगर किसी पेशेंट को प्रॉब्लम हो रहा है, एंड आई नो डॉक्टर उषा शर्मा मैडम कैन हैंडल, हाउ कैन आई सेंड पेशेंट टू द पटना टू डॉक्टर उषा मैडम? सो वी हैव टू मेक अ टीम ओवर देयर ओनली. डिलेज इन केयर आर द मेन थिंग, एंड डिलेज इन ट्रांसपोर्ट इज अ मेन थिंग. सो एवरी गोल हैज़ अ क्लियर रोड मैप. आप अगर आप रोड मैप होगा तो आप उस पे से होते जाओगे. और एक चीज़ बहुत सिंपल है हर चीज़ के लिए, कि अगर आपको जस्ट सपोज मुझे कार चलानी नहीं आ रही, मैं एमडी हूँ और डॉक्टर मैं कह रही हूँ मैं नर्सिंग होम चला ले रही हूँ, मैं हॉस्पिटल चला ले रही हूँ, बट मुझे कार चलानी नहीं आ रही, और एक अनएजुकेटेड बंदा वो ट्रक भी चला रहा है, वो बस भी चला रहा है। तो एक इसका ये है कि करत करत अभ्यास के जड़मति होत सुजान, आप रेगुलर ड्रिल करेंगे तो आपको वो चीज़ आपके उसमें भर जाएगी, और आपका स्टाफ स्पेशली, और आपको इतना हो जाएगा कि प्राइमरी हेल्थ आप लोग को सब आता है, टर्शरी केयर में सबको सब आता है। ऑल ऑब्स्टेट्रिशियन आर हाईली एम्पावर्ड, सेफर, एंड दे आर लिविंग इन अ स्ट्रॉन्गर environment, but we want to train all those patients who are to the reaching to the unreached in the that level, that if we set our goals, if we teach them, then they will do work like this कि patient को जैसे एम्बुलेंस चल रही होती है तो इवन रोड पे चलने वाले सबको पता है कि इसमें कोई पेशेंट है, हमको इसको जगह देनी है, इसको आगे करना है। सो दैट वे अगर आप एक्लेम्सिया के पेशेंट के साथ भी हम लोग ऐसा करेंगे तो फर्स्ट मिशन पे हम लोग अगर फोकस करें कि इसको प्रिवेंटेबल है, वेस्ट ने कर लिया तो हम भी कर लेंगे, हम इतना पीछे थोड़ी ना, इंडियंस में भी बहुत दम बूता है। तो अगर हम क्लिनिकल पिक्चर ऑफ HDP देखेंगे तो इसे सिंपल सा है, प्रेग्नेंट वुमेन विद द ब्लड प्रेशर हायर देन 140/30। व्हाट डज इट मीन? इट मीन्स कि देयर इज अ सिंपल डायग्नोसिस इज सिंपल, 140/90 ब्लड प्रेशर, कोई अल्ट्रासाउंड कोई MRI की जरूरत नहीं पड़ रही है आपको। सो दैट मीन्स इफ यू कैन डायग्नोज एंड बिफोर 20 वीक्स एंड आफ्टर 20 वीक्स, बिफोर 20 वीक्स if it is present then it is either chronic hypertension or it is a superimposed preeclampsia. Then preeclampsia, what is preeclampsia? Preeclampsia is a gestational hypertension where in pregnancy BP is more than 140/90 and any of the complication of the organ dysfunction develops, like proteinuria, maybe maternal organ dysfunction, AST, ALT, these enzymes, they are doubling, pulmonary edema and uteroplacental dysfunction. Management of severe preeclampsia is a antihypertensive, anticonvulsant and corticosteroid if needed. So अगर हमने टाइम से ये अब जीरो एक्लेम्सिया मिशन पे आते हैं तो मंत्रा हमारा क्या है? मंत्रा हमारा ये बड़ा सिंपल सा, भी प्रतिभा ने सब कुछ समझा दिया, डॉक्टर प्रतिभा ने से पहले, तो उसका मैंने एक शॉर्ट बनाया, उसका नाम है ग्लैकामेगा. So what is the to reduce the that simple formula? It is that can we name to the eclampsia care bundle, though in books there is nothing like eclampsia care bundle, but we can think of making that way, that if you know what is glycamegar and what are the regular drills which are needed. So justosis score, this is something, as she said, that this has been very well endorsed by the WHO, FOXY, and it was made by our from a doctor from Maharashtra, Dr. Gorakh Mundrapkar, and they have taken risk factors and they have given it name that there are low grade, high grade, and then medium blood pressure. There is a list, and in the prediction, see, she said, very rightly, she said that there are hardly any proper predictors, but this fetal medicine group has said that medical history, medical characteristic and pregnancy characteristic mean along with the mean arterial pressure and mean uterine artery pulsatility index and PLGF concentration. These soft markers, somehow they said that they are very good predictors for early onset. Mind it, it is for the early onset. And this glyca, ये घंटी हमारे लिए बजी? नहीं, ठीक है. Okay, टाइम हो गया? अरे बड़ी जल्दी हो गया टाइम. Zero eclampsia. So this glycamegar is justosis score, low carbohydrate, aspirin, calcium, antihypertensive, Maxel for all severe hypertension at 0 hour management. So this is giving the taking the remembering the universal screening. Yes, India is a low resource country, low income country, and we know why the aspirin is very important and how it is. एक आपको अगर कोई भी आपको risk factor लग रहा है, just please give aspirin without even thinking, because it is such a cheap thing and it's not going not having many side effects and it is easily available and it is preventing a lot. So and second mission is a little difficult because saving the patient from the death. So again same the bundles. So agar you know the PT severe variety, if you know what is the severe variety of the preeclampsia, because when you diagnose there, and remember any fit in the later half of the pregnancy should be treated as eclampsia, and then this indicator indicators of severity of preeclampsia are about this. Especially the main thing is a BP more than 160/110. So one thing we should always remember that eclampsia is an emergency. You have to give all the first aid treatment, you have to stabilize the patient, but it should not be treated at the small nursing home. This is a take home message. And the 0 hour पे आप क्या करेंगे mainly because first hour is very critical and first hour management is very well if do then half of our job is done and taking care of the patient can go into the DIC patient after that this can develop cerebral hemorrhage, and so when the patient is having eclampsia she can have become unconscious, she can go into coma, and at that time just saving her from hypoxia is very very important. So the goal of the bundle approach is standardize the care protocol, simple structured patient nursing and medical care drills, जैसे अभी अधूना प्रोग्राम था, and reduce variability. सब लोग एक ही जैसा करेंगे तो better रहेगा, and this is called adherence to recommendation and more improved outcome. And obstetric unit readiness is very very important, and these two are प्राइमरी हेल्थ सेंटर पे क्या करेंगे, सेकेंड हेल्थ पर क्या करना है, दैट्स इज वेरी वेरी इंपॉर्टेंट. स्मॉल नर्सिंग होम में जनरल केयर, स्टेबलाइज द पेशेंट, आपको जल्दी जल्दी उसका डिलीवरी करने में नहीं लग जाना है. देयर इज अ वन थिंग इज कॉल्ड संजीवनी बूटी, दैट इज अ मैक्सल, एंड अर्ली रेफरल, अर्ली इफेक्टिव रेफरल इज वेरी वेरी इंपॉर्टेंट, टेकिंग केयर ऑफ ऑल द टूल्स एंड दिस डूइंग, एंड द सीरो secure IV line is very very important, and catheterization, like simple thing which we all know, and control the hypertension with antihypertensive drip and early referral. So whatever we do, then tertiary care में obstetric management, medical management is very very important. चल रहे हैं
इनॉग्रेशन भी अभी करना है,
आगे
मैडम भी आगे
हॉस्पिटलाइज. वाई वी आर नॉट एबल टू डू द मैक्सल, बिकॉज मैक्सल में बहुत वैरायटी है, लोगों को डर लगता है कि मैक्सल वगैरह हमको याद नहीं आ रहा कि क्या आ रहा है. तो IV मैक्सल इज वेरी वेरी इंपॉर्टेंट, एंड मैक्सल डोसेज इज वेरी वेरी इंपॉर्टेंट, हाउ वी आर एबल टू मेंटेन द डोसेज एंड एडिशनल डोज प्रोग्राम. वी मस्ट नो द ट्रिपल एक्शंस ऑफ द मैक्सल and toxicity of the maxil, and last message is women die of complication, any woman, any disease. So maternal health shows the health system, and a system saves a patient. Remember, if you work in that way system and the bundle care, then you save. So learn, practice, and improvement is very very important. Thank you for giving me so much time.
Thank you, Chairperson. Yes.
System should be like Nikhil. हम यहाँ पे ज़्यादा देर खड़े नहीं होना.
Thank you, Dr. Archana, for such a detailed talk.
Thank you, ma'am.
Very informative, very updated. Thank you so much.
Thank you so much. With that, can I request the chairpersons and the speakers?
Just a compliment. It was a very nice talk. Like, it was excellent.
Thank you. With that, we would like to get started with the inaugural ceremony. Can I request Dr. Ranjana Sinha Madam to please take the proceedings further? The chairpersons, the speakers, please join us next to the backdrop for the photograph. Madam.
Very good morning and a very warm welcome to all our senior faculty members and dear delegates. Now we will have a very short inauguration of our scientific sessions. First, I would like to express grief over Madam Vinita Singh's father's death. Due to that reason, Madam Dr. Vinita Singh, scientific chairperson, is not here, and in her place, I would request Dr. Alka Pandey, Madam Chairperson, Reception Committee, to be over here, and I request Dr. Meena Samant, our organizing chairperson, to kindly come over the dais. Dr. Amita Sinha, our organizing secretary, who is doing so hard work. I think she is not over here. And may I request our Madam, senior most Madam in the hall, Madam Manjugita Mishra Madam. And we have our President-elect, Dr. Bhaskar Pal, sir. We are very privileged to have you here, sir. Please come over the dais for the small inaugural lighting ceremony. May I request our scientific team, Dr. Monica Anand and Dr. Bhavna Tiwari, to come on stage. Dr. Monica. So I would request our organizing chair, Dr. Meena Samant, for a brief welcome.
respected seniors and my dear friends, a warm and hearty welcome to each one of you. Respected Dr. Manju Geeta Mishra, Madam, we are very honored to have you here for a small lighting of lamp because we think it is very auspicious and it's part of a ceremony during any scientific sessions. So ma'am is here and she is obliged for walking down from her own session. So thank you ma'am for that. We have Dr. Bhaskar Pal sir here. Welcome all of you. I hope you have a great session, scientific session here today, and we will all be here till tomorrow evening, and today evening we have the inauguration. So I also welcome Dr. Jaideep Malhotra, who has just entered the hall. So ma'am, I also ask you to please join us for the lighting of lamp. Thank you.
I request Dr. Anjana Sinha and Dr. Mini Anand. Is she here? The joint organizing secretaries, please come. Welcome Dr. Jaideep Malhotra ma'am. Ma'am is our narrator today and please join in the lamp lighting ceremony.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः
Thank you so much. Can we have a group picture?
I thank Madam Manju Geeta Mishra, Dr. Bhaskar Pal sir, and all the guests for the lighting of lamp.
Thank you. As they take a group picture, everybody look into the camera. 3, 2, 1, smile. Ek aur le le. Thank you so much. With that, we would like to get started with our next.
Just a few words. I would like to have a few words from Dr. Manju Geeta Mishra ma'am.
Very good morning to all of you. First of all, I thank Dr. Jaideep Malhotra, Dr. Bhaskar Pal for gracing this occasion because Dr. Jaideep Malhotra came in time. So thank you very much for taking part in the inauguration of scientific session. And you all have heard and seen how packed the scientific session is there. 2 days, 3 days, 2 days, 1 day was workshop, and then 2 days this scientific session is going on, and how all the subjects which has been chosen and the speakers, they have given justice to the topics and the subject. I must congratulate the Meena Samant, Amita Sinha, and scientific chairperson for sorting out this beautiful scientific session. So thank you very much for this.
Thank you, madam. And 2 words from our president-elect, Dr. Bhaskar Pal sir.
Thank you very much. And it's always a pleasure to come back to Patna, which has one of the most united and well-knit team, and now I can see 4 generations here together. And I think in the last 1 year, I think hats off to Meena, Amita and your team. I have come for 2 national conferences, and your energy for organizing conferences. Jaideep had said कि तुमको conference करने का कीड़ा बैठ गया है. She told us after AICOG. So I think 2 brilliantly organized national conferences, now this, and I'm sure that looking at the topics and the faculty, it would be a great conference. Thank you for having me here.
Thank you, sir. And Now over to Nikhil for,
Yes, ma'am.
for the
Thank you so much.
sessions. Thank you very much.
Thank you so much. We have our first speaker already on the stage, Dr. Bhaskar Pal. Can I request our chairpersons, Dr. Kumkum Sinha, Dr. Geeta Sinha, and Dr. Usha Kumari to please join us on the stage. We have Dr. Bhaskar Pal already taking the dais.
At the outset, we would like to thank the organizers for giving us this opportunity to chair this prestigious session. Now we are going to start with the other session. One of our chairpersons is not here as yet. So the speaker for this session is none other than Dr. Bhaskar Pal, a very humble, down-to-earth, towering personality in Foxy, who very successfully organized the Calcutta AICOG 2023. He's the dashing president-elect Foxy, who will take charge in 2026. He's senior consultant gynecologist Apollo Multi-Speciality Hospital, Kolkata. One more two Thursdays. Immediate past president IAG, Foxy representative to Suffolk, past president Bengal Obs and Gynae Society, author of over 40 papers and book chapters. He is going to talk on an important subject, that is transforming severe PPH management in India, role of recombinant activated factor 7. This is the new thing, medicine that is being tried. Previously it was tried in hemophilia. And now it is the new thing that has very quick action and easy to use. And so we will hear all these details from our eminent speaker. Over to you, Dr. Bhaskar Pal.
Thank you, Kumkumdi, for your kind introduction. Whenever we talk of PPH, I think the first thing to say is that we've done really well. PPH is a major contributor to maternal mortality, and the maternal mortality from the time that I was training was over 600, and now pre-COVID it was down to 97. We do not know what happened during COVID, and it is largely due to our emergency obstetric care. That is what we traditionally call the low-hanging fruit, which means you do your AMTSL, you do your institutional delivery, and you will be able to control the majority of the deaths. Then comes the more difficult step, that how do you further reduce the mortality? And we all know how to manage PPH. We talk of a lot of things. We talk of bundle approach, and this is essentially a case of those refractory PPHs, and what is the role of recombinant factor 7. Now I am pleased to know that Patna is one of the cities where recombinant factor 7 is used possibly the maximum in postpartum hemorrhage. So we have a panel discussion after that, and we have a wealth of experience there. Now we are trying to get, as I said, the MMR below 70 by 2030, and that becomes a more difficult job because the easier ones we have controlled. And so although the maternal mortality rate has come down in India to less than 100, there are 6 states and 128 districts in India which still have an MMR over 200. And as you know, that the Adhuna project is also directed at 4 states looking at that. Now we all know PPH still contributes to around 23% of maternal death, and we will talk of recombinant factor 7A. Where does it position itself in the management of PPH? It is now approved for the treatment of severe PPH. It is not a new molecule. It has been there. It was launched initially more than 7-8 years back. And the approved indication is treatment of severe PPH when uterotonics are insufficient to achieve hemostasis. So when PPH occurs, we say that with medical management, and medical management includes uterotonics, tranexamic acid, and uterine massage, we will be able to control 90% of PPH, and the rest 10% will go for surgical management. And this is exactly where the recombinant factor 7A comes in, that when uterotonics fail to control the PPH, before we move on to the surgical procedure, ideally we should try the recombinant factor 7A, which is now approved in 58 countries, approved by the European Medical Agency. So it can be used to treat bleeds and it could be used to prevent bleeds. It is used to prevent bleeds only in those who have a congenital factor 7 deficiency. Otherwise, we use it to treat bleeds, and this is used in trauma, this is used in postpartum hemorrhage and other bleeding. So it is approved for treatment of severe PPH, as we said, and the advantage of is that once we recognize a bleed, it is quick, we can quickly reconstitute it. It is a low infusion volume, so it can be given quickly, and the peak activity is achieved within 5 to 10 minutes. So we don't have to, while we are preparing for a surgical treatment, we can give the recombinant factor 7A, and within 10 minutes we will know whether it has worked or not, and that way we can, in many cases, prevent the surgical management. So I will skip this slide, and we'll see that what is the place of recombinant factor 7A in the treatment algorithm of PPH. Can I have a pointer, please? So whenever the PPH occurs, pointer? Okay, thank you. So whenever PPH occurs, what we do is we now go for a bundle approach. We go for oxytocin, prostaglandin, methyl argometrin, whatever we can, and along with that we give tranexamic acid. And severity of PPH increases if the bleeding is not controlled. The patient will go into consumptive coagulopathy. So what is important to institute other measures before it is too late? And what are the other measures? Obviously the general measures will start much earlier, but this is where the factor 7A comes in, along with mechanical intervention like uterine or aortic compression. You can use the balloon tamponade, or you can use the suction cannula. If there is retained placental beads, we can do that. All this is what is bundle approach, and that is how it continues. And if this fails, that is when we move on to surgical procedures like compression sutures or devascularization or hysterectomy. So this is where factor 7A comes in after we've given our oxytocin and tranexamic acid. If that fails, then while we are planning a surgical procedure, that is when we give the recombinant factor 7A, and that might be able to prevent. So there will be 3 situations that would arise. Number 1, the bleeding gets controlled, so you watch the patient and do not go in for a surgical procedure. The bleeding is same as before, you move on to a surgical procedure. The bleeding reduces but not completely. There you can repeat a second dose of factor 7. So there are randomized controlled trials from France and Switzerland, and it shows that there were 2 issues. Number 1, what is the efficacy? And efficacy was essentially looked at by prevention of surgical procedures and also looking at safety. Now there is a theoretical concern of thromboembolic events, and that is why some of the European countries were reluctant to use the factor 7. And this is a study design, and the bleeding was considered to have stopped if the estimated blood flow reduced to less than 50 ml in 10 minutes within 30 minutes of randomization. So these patients received the recombinant factor 7 in a dosage of 60 microgram per kilogram of body weight, and the other patients, 42 patients, were randomized to what is our standard treatment, and then we looked at treatment success or not. So if you look at the chances, that is that efficacy of the primary efficacy outcome, in 93% cases in the women who received factor 7 did not require a surgical intervention, whereas 52% women in the other group did not receive. So you can see that if you do not give factor 7 in this group, about 50% women landed up with a surgical procedure, and if you give factor 7, about 10% women landed up with a surgical procedure. So which means that is the proof of efficacy essentially. There are Indian experiences. They've been used in, the problem is that earlier when factor 7A first came into the market, which would be around 7 to 8 years, we were positioning it something that we give that when the patient is in a moribund condition, which means we've tried everything, our back is to the wall, nothing else is working, and then we gave it Novo 7. And we've given it in PPH, we've given it in our ITU for other bleeding as well. Some of the cases it worked, some of the cases it didn't work. Now we know that we should not actually leave it for that late. don't have to give it as soon as the patient has PPH, because then we might give it to a lot of women unnecessarily. We give the oxytocin, so 90% cases will resolve. In the other 10% cases, we give it at that stage rather than doing the surgical procedures and then see patient is still going on bleeding and then hoping that this will work. So there are several reports from India, from various parts of the country. And this is actually from Hyderabad, a series of 10 cases, and it has been used in atonic PPH, placenta accreta spectrum, etc. And there were conditions when it was associated DIC as well. And the problem is that in this series of 10 patients, 9 patients already had undergone the hysterectomy before giving the factor 7. And that is what now I think we are time to relook at it, that yes, we can give it even after hysterectomy if the patient is bleeding, but ideally, if we can, we should give it before initiating the surgical treatment. And that way, possibly, this would have been better. And if you look at it, what happens is that, even in this series, the requirement of blood product transfusion decreased significantly. Blood product transfusion decreased significantly after giving the factor 7. So this is again other studies from here, so I will not go into that, but what is important to understand is from the Swiss and French study, what we know that there's a significant decrease in patients requiring the surgical procedures in PPH. And from the Indian studies, obviously we are many places in India a little conservative when it comes to using a medication which is a little expensive, and that is where it is delayed, the usage is delayed. But even there, the requirement of blood products before giving the factor 7 and after factor 7 is a significant difference. I think I would essentially stop here, because rest of the stuff I would hope to use in the panel. The other important issue is from the Swiss and French study, what we found is that there is no increase in thromboembolic events when you use recombinant factor 7. So essentially, in worldwide 5.4 million doses have been used, and the indication and the incidence of thromboembolic events is really small. And in the group, in the Swiss and the French study group, the incidence of thromboembolism was the same across the placebo as a normal group which treated with the normal protocol and factor 7. Now we have to remember is that women who have a massive PPH and also 1 and 2 have a surgical management are already at a higher risk of venous thrombosis. So that is why when we give a drug and a venous thrombosis occurs, we would be more inclined to think start thinking whether there's something to do with the drug. But when you put it across in a comparative or a randomized trial, the results are that similar venous thromboembolic events whether you give factor 7 or not. And this is again looking at 446 women exposed to factor 7A as opposed to about 1700 women with severe PPH who did not give factor 7A. You can see that the thrombolic events are more or less similar. So this is essentially something that we've spoken about, and this is what is the drug controller of India's approval, and that is you can use recombinant factor 7A in severe PPH after using uterotonics. Thank you, and I think over to Kumkumdi.
A wonderful talk. So much we have been specially asked not to ask questions because we are having this panel discussion on the same topic, and moderator is none other than Dr. Bhaskar Pal himself. So I had a few questions, but I will sit and see in the panel discussion.
They say sir has finished 1 minute before.
Okay.
So.
No, I think what will be easier is after the panel, anything that is not addressed, among the panelists have a wealth of experience in using factor 7A, and we can take the questions if you have time from the floor.
Already 2 minutes have passed.
No,
so
no,
any comment on side effects of
No, as I said, the only side effect, as I said, that there is a theoretical worry as having a venous or arterial thrombosis.
Yes.
But if you look at the comparative data, it doesn't seem to happen, and at the present moment, A lot of women have received it. It is same as the background risk.
It is also being used in all the hospitals itself
Yes,
in Patna, in
absolutely.
government hospitals. And there's some reports saying that there's a risk of heart attack and this thing also in some places I
No.
read.
Actually, to be very honest, that arterial and venous thrombosis was the only red flag, but at the present moment, the data looks pretty reassuring in terms of that.
Thank
Yeah.
you, Dr. Bhaskar Pal. You have spoken very nicely about the recombinant factor 7A. We are using in NMCH, it is used, and we have saved so many lives before but after the failed oxytocin or other oxytocic drugs. So, what hemoglobin level should be the baseline before?
Madam, it is nothing to do with the hemoglobin level. I think in an acute bleed, a hemoglobin level has no significance. I think when we identify PPH, what we do is we give uterotonics, we give supportive management, and if with uterotonics, if the bleeding is not controlled, that would be the indication for giving factor 7A.
All right.
The
With
problem is that 7-8 years back when it was first launched, we were waiting for the patient to go into DIC before we gave factor 7. And I think the efficacy would improve a lot provided we give that after the medical management fails and the surgical management is instituted in that gap.
In between medical and surgical. Thank
Yes.
you very
In
much.
between medical and surgical.
In between medical. Thank you very much.
Thank you so much, chairpersons.
So wonderful talk by Dr. Bhaskar Pal. Thank you so much.
Thank you so much. I would request Dr. Bhaskar Pal to please be there.
We need 2 more chairs, please.
Yes, we will put it up. Can I request the panelists to please join us? We have Dr. Anjana Sinha, Dr. Amrita Preetham, Dr. Nutan Narayan, Dr. Priyanka Shahi, and Dr. Raj Rani Chaudhary.
Oh yes, sure, absolutely.
Requesting Dr. Bhaskar Pal to please join us on the stage as he's the moderator. I know we all want to take pictures with him, but he's right here. He's the star, of course, and he's going to run up on the stage. I know that because he also likes to keep it on time. Over to Dr. Bhaskar Pal. Thank you so much.
Can I request Dr. Geeta Sinha to join as well, please? Yeah. I thought you were the expert on the panel. Yeah. Yeah, while we settle down, I think I request all the panelists to introduce yourself, and we'll start off with that where you are working and how many factor 7s you've used. We'll not go into the cases at the present moment.
Myself, Dr. Anjana Sinha, I'm professor in Department of Obs and Gynae in PMCH Patna, and I have used this factor 7 in many of my cases.
Yeah, I think you mentioned a number to me, 45 or 65.
No,
yesterday.
in total we have used in about 33 patients.
33 patients,
Yeah.
okay. Priyanka.
Hello, sir. I'm Dr. Priyanka Shahi. I'm senior resident in PMCH, and we have used total 66 vials in 33 patients.
Yeah.
My name is Dr. Raj Rani Chaudhary. I'm professor at Nalanda Medical College, and we have also some experience of using in 5 or 6 cases.
I'm Dr. Geeta Sinha. I'm professor and head Obs and Gynae Department, Patna Medical College, and under my supervision and encouragement, we have done a lot of work with Novo 7, and my team is here, Professor Anjana Sinha and my resident. They have actively been involved in this trial.
Myself, Dr. Nutan Narayan, Assistant Professor NMCH, Nalanda Medical College. We have used in about 5 patients, but initially we had used in only 1 vial per, so that was a bit, but after that we came to know that no, we have to give more, and so the results we have
I
found
will come
quite
to
good.
that, yeah.
Myself, Dr. Amrita Pritam, I'm assistant professor in SKMCH, Muzaffarpur. We used in total cases, 5 cases, sir.
Okay. This is a question to all 3 units, that how was it like to use in severe PPH before factor 7A came, and what did you feel there was any unmet need? We were practicing managing PPH without, so what can you see that has made a difference from pre-factor 7A days and up to post-factor 7A days?
Earlier also we were using different uterotonics and mechanical methods. But with this recombinant factor 7A, which was already used in cases of hemophilia, there was a level of confidence in all of us that yes, we have another weapon to save the patient. And we have seen a major difference in the shift. Like we managed to save 23 patients out of 33 patients. There were 10 mortalities. But in those cases, it was mainly because ours is a tertiary healthcare center, so these patients were already very moribund when they had come to us. They were already in shock and late DIC. So it is, as this drug, we all know that we have to use it timely, as in, we don't have to waste time thinking about looking for the response of recombinant factor 7A. Since we have this drug, we have to use it right in time in the treatment algorithm. Of course, excluding other factors also, like if there is trauma, we have to first tackle the trauma and then we have to give this. So as we will head later to the discussions of different cases like after vaginal delivery or after cesarean, during cesarean. So mainly during cesarean sections, we first, for all the high risk patients, like in cases of abruptio placenta, in PPH cases, in twin deliveries, we were expecting PPH in these cases, and we had this Novo 7 with us. So we were confident that we could manage to save this patient if uterotonics failed.
Okay. Anybody wants to add anything else?
See, I have got one experience of doing hysterectomy in a primary patient, and she was referred from Danapur. That time we didn't have recombinant factor 7. So now I think with this drug we are very confident that we can try. But the first line we have to try uterotonics. This is a second line drug. And after that we'll think of uterine artery embolization or hysterectomy or any other procedure like this.
We had a case of abruptio placentae, and we took her for the cesarean section, and after delivering the fetus, she was a primary gravida, and then what happened, she started pouring. All the uterotonics were given, and even some compression sutures were taken, but still the patient, and she was a primary gravida, so we were thinking that if we had to resort to hysterectomy, that was a big issue. Then we gave her recombinant factor 7, and the bleeding stopped. And meanwhile, the patient was inside the OT. We were during cesarean section. We kept her in the OT, and the bleeding stopped, and the patient recovered. The only thing we saw in the post-operative period that maybe it was due to some other factor. The patient developed some. The temperature drastically dropped. She had hypothermia. But then all our team, we gave her resuscitation and everything, and patient improved, and there was no bleeding after that. So it was a good experience, because we were thinking that if we had to resort to hysterectomy, how will we face the attendants and how they are going to react and everything all, even after hysterectomy, whether the bleeding will be stopped or not. So this was this is a new feather in our cap.
Dr. Nutan?
I want to say that before this factor 7 was there, factor 7A, what was the problem that the major vessels, like if we gave uterotonics, the uterus contracted, and if it was bleeding, then we could ligate the major vessels. But the problem was there when there was some oozing, like placenta previa, and the bed started oozing. So we used to put pressure and hot towels and everything, and then take it out again. Again it is oozing. And so the last step, like she said, it was hysterectomy. And this oozing is what we have realized with this factor 7A. This oozing is very much controlled by this factor 7. So that is the
So
real
essentially 3 things come out. Number 1, with using recombinant factor 7, we might be able to avoid a hysterectomy or other surgical procedures. Number 2, it is very useful when there is generalized use. And number 3, what we used to do before, and we should not be doing that, we should be using it sooner, is when our back is to the wall. Patient is in DIC, we think the patient is dying, so let us give one more last attempt. You want to say something,
Sir,
Dr. Anjana?
even after hysterectomy, if you're bleeding from
Yeah, we'll come to
walls,
that. We will come to that. I said, Nikhil, can I have a timer, please, to have an idea? Okay, I think we have already done this bit, that you've described the cases where you've used it. I think Dr. Rajrani, you were talking about using it when the patients were already in DIC? Or no, or Anjana, you were talking about patients, Priyanka was talking about patients who were already in DIC. I think what is important was that I would like to hear from all of you. As I would say, I would position factor 7A as giving it in a normal patient who is in our unit and having a PPH. I would give it after giving uterotonics without wasting any time while getting ready for a surgical procedure, so that we don't. So I would ask each of you, how would you like to position that when to give the recombinant? I will start from Madam.
Yeah, I think we should not waste our time before resorting going to any surgical procedure or something. We should give a recombinant factor because it works through the intrinsic factors and makes small thrombus.
I will make a difficult situation. Now, when somebody has got a vaginal delivery and having a PPH, it is easy because we'll take us around 20 minutes to get the theatre, everything ready, and in that 20 minutes we will know if recombinant factor 7A has worked or not. In a cesarean, if it is bleeding and we give factor 7A, how long are you going to wait before you resort to your surgical management like compression sutures and devascularization? That's, 10 minutes with a patient open is like 10 hours.
I think both the procedures should go side by side.
You
We
will
will give recombinant and then we'll go.
You'll go with the conservative.
compression.
I think that is a very, very practical way of looking at it, that you will give the recombinant factor 7 and go ahead with your conservative surgical measure, so that by that time you will know whether you've been able to avoid a hysterectomy. Does everybody agree with it, or you? Okay, I'll come to Madam.
We should, as you rightly said, that we should do either compression or the uterine revascularization, and simultaneously factor 7 should be given, because it will take 5 to 10 minutes for it to act, and during that time we can decide whether to proceed with either hysterectomy or not, because it is a difficult decision to make at that time.
Dr. Nutan, I think you, Dr. Amrita.
Even, sir, after cesarean section, we develop severe PPH with factor 7 and the combined uterine embolization.
Okay.
Sir.
Okay, Nutan, madam.
I want to say that because it is too expensive, I don't think we should use in every PPH along with the devascularization. First, we should try the devascularization, and then if we see that it is not working, because after devascularization, it should stop immediately. There should not be any delay. And if it doesn't stop immediately, then we give factor 7.
And then you wait for how long before doing a hysterectomy?
Then, of course, we have to wait for it. It works for 3 to 4 minutes, 10 minutes
10
at least.
minutes.
10
Sir,
minutes.
one thing
But
I want to
it will
mention,
come
sir.
down, we can see whether the bleeding has stopped. Coming down.
You know,
or
madam,
not.
the problem
It is
is,
coming
I
down.
always teach my juniors, in a placenta previa, pack in a mop and do not touch it for 5 minutes, suture your angles, do other things. And that 5 minutes is when you keep an eye on them. At 3 minutes they finished everything, they are trying to take a corner away and to see if the bleeding has stopped. So I think 10 minutes is an immense time in the theatre. So the other problem is that, yes, the patient is spending so much of money, but the money should be well spent. So the moment we say we are waiting for uterotonics to work, we've excluded 90% of patients. But we possibly do not want to take it to a stage there, if we do not, if we give it after doing the conservative surgical procedures, the problem is that we might be tempted to do a hysterectomy before we realize whether it has worked or not. So practically, I thought that is a better approach to take for doing the conservative procedures. I just want to say, we emphasized this when we did the PPH conclave here, that if you look at protocol, some protocols say, do compression sutures first, then you do devascularization. And devascularization means only uterine and ovarian, no internal iliac, for atonic PPH. And some protocols say devascularization first and then compression. Our practical experiences don't look at that, do both. Do a compression suture and devascularization, uterine and ovarian together, and then wait to see whether you need to do anything. So I thought it is more practical to give it before you do the compression, and as Nutan madam said, it is possibly more economical to do it after doing the compression and devascularization, but then you have to have the nerve to wait for 10 minutes to see if it is worked or not. Yes, Geeta.
Now, this is a panic situation, and PPH is the fastest killer of women. So, I agree with the approach that we have to do everything, and I mean almost simultaneously. And in the 5 minutes we wait and do the
I
conservative
think we'll
surgery.
be lucky if we can avoid a hysterectomy, isn't it? Because a compression suture devascularization is okay. Now, I want each of you to take up one of the situations and your experience. Now, I will take out the difficult one. Dr. Amrita, you were talking about PPH post-hysterectomy?
Yes, sir.
Your experience of using recombinant factor 7A in PPH post-hysterectomy. Nikhil, if you can tell me when 10 minutes is left, please. Okay, fine. Yeah. Okay.
Sir, during there is a case of severe abruption of placenta, or we tried a compression suture after hysterectomy. There was also bleeding from ward. Then we tried relaparotomy, and then before doing relaparotomy we gave factor 7 and the bleeding control.
Okay, excellent. And this is exactly what Nutan madam was saying, that use it in when there is generalized oozing. Severe PPH during a cesarean section, or let me say severe PPH after a cesarean section. Has anybody used that? That you've done a cesarean, you've come out, patient is out, and then patient started bleeding heavily, and anybody has used it in that situation? No. Okay. But that can be used. Severe PPH during cesarean section. At what point would you use it? Means anybody who has used it during cesarean section.
We have given this during cesarean section, as I said, that patient was pouring, and the compression sutures were not working, and devascularization was also done.
That's the standard one. The second question I ask is, when you are doing it for a placenta previa or a placenta accreta, you will have a low threshold for giving this. Then when do you give that? Prophylactically or?
So in cases of placenta previa also we can go for this either intrauterine this balloon tamponade can be given in this case, or local sutures in cases of traumatic, or in the cases of placental abnormalities we have to go for surgical approach.
So I think Nutan madam said a good thing about placenta previa, that if the placental bed is oozing, give this and keep a pack and then you see. But if there's a placenta percreta, when would you has any role in placenta percreta?
We lost severe blood loss during placenta accreta. What happened during placenta? There is a severe massive hemorrhage during hysterectomy also. So we can already give factor 7 that reduces the blood loss during hysterectomy.
Okay, but I think the price is justified when you are trying to avoid a hysterectomy. But to reduce intraoperative blood loss, we have cheaper options like aortic compression and etc.
It also reduces massive blood transfusion.
Okay. Severe PPH following vaginal delivery, we've already spoken about. That's the easiest way to decide when to give it. Your uterotonics have given, but you think the patient now needs a laparotomy. While you're preparing for laparotomy, give it. And the other ones we have discussed. Anything to add about severe PPH during vaginal delivery, Priyanka?
Sir, recently, just last Tuesday, we have used this Novo 7 in a case of severe jaundice. And this patient, instrumental delivery was done, and bleeding stopped like magic. We explored the uterus, everything. Episiotomy wound was, because this patient was again referred in second stage. So there was edema all over. Episiotomy was a bad episiotomy. It was oozing, and we gave Novo 7. It worked like magic. We repaired the episiotomy suture and bleeding stopped. But we lost this patient because she went into hepatic encephalopathy.
This is exactly when it was first launched. We were using in your ITU not only for obstetric patients, for everybody, but we are limiting it to patients who are going into DIC, and that is where we are losing too many patients. So what we know now, that yes, it is useful in these circumstances, but it is better in atonic PPH to give it before the patient gets into DIC. Anybody else has any peculiar case like Priyanka spoke about a patient with jaundice, possible coagulopathy. Anybody has any others?
One case of manual removal where whole of the placenta could not be taken out because of focal adhesion. So in that case we used Novo 7 and really the bleeding stopped and the patient was saved also.
Focal
She had
adherent
torn-
placenta.
Yes.
Nutan madam,
I want to
severe
ask-
PPH during C-section, or we've already addressed
Sir,
it?
I want to ask one question. Like this
Madam,
time,
you are the panelist. You have to answer questions. You are the expert.
no, like recently we had one patient. She was having PPH, and we wanted to give this, but before that a blood was given, and she had reaction to that blood. So the anesthetist, they refused. They said that no, we will not give. This is also a blood component, so we will not. So can we do it? or
I
not?
think it is. I think it is pretty reasonable to wait for a few, say 15 minutes or 20 minutes. Whenever somebody has got anaphylaxis to something, we don't want to give something which also might cause anaphylaxis, because we will not know what the anaphylaxis is due to. So I think it is very pragmatic to wait for 15 minutes, give her antihistaminics or steroids, and before you want to give this. And if you think it's life-saving, I think it's prudent to give her steroids and then give it, rather than taking a chance. I think PPH during cesarean section we've already spoken about. So basically that is what is pragmatic, that after doing your compression and uterotonics it doesn't work, then you give the factor 7, and then you go on doing your compression sutures and devascularization, and then assess if the bleeding has stopped. We don't care whether it is stopped because of factor 7 or because of compression sutures, that the patient doesn't need a hysterectomy and she is well, that's we are happy with, isn't it? Okay, severe PPH after C-section, but this is something that we really do not see as a big problem. I think in good hands, the severe PPH would happen and be managed during cesarean section.
Sir, I want to add something over here. Like we also receive few patients, some referral patients from PHC and district hospitals. Cesarean section was done there, and the patient is coming postpartum. We have used in such cases also, 1 or 2 cases, and it was a success here also.
Okay, Dr. Amrita, I just want to ask you, is that in peripheral district hospitals, do you think there is a role
Yes,
of
sir.
giving it before shifting the
Yes,
patient?
there is a role, sir. Because generally in our hospital, they are referred from PSC. A patient already bleeds too much. So if it is available in peripheral hospital, after giving uterotonics, we can give factor 7. Then we transfer to patient to higher center.
Okay.
That would
I think there
generally
is
reduce the loss.
if it is possible, I think that is the next step. We try to use it before transfer. And that would be a very useful thing to do. And you can, if there's a facility to use a tamponade or a suction device along with factor 7, that will be great. Dr. Amrita, dose of factor 7 in severe PPH, what dose that you use?
Sir,
We know standard
we
dose.
use recommended dose, sir.
I'll just come to that. The
Yes,
standard doses is 60 to 90 microgram per kg.
Body
We
weight.
have always said that use 60 because we want to save money. But from your experience, from the 3 units, what is the dosage that you use?
Sir, we used according to the recommended dose, 60 to 90 microgram per kg body weight.
Okay.
We used one vial, which is 1 milligram, and then which is available with us, and then we wait for 15 to 20 minutes and see whether bleeding has stopped or not. If there is a need for second, we give after 30 minutes. But usually we give 1 gram vial.
You give 1 gram vial.
Actually, when we were not knowing it, we have used also 1 milligram vial, and the patient were good also. But then when we came to know that it is 3 milligram, we usually give 3 milligram. And in one of our cases, we have repeated this dose also after 2.5 or 3 hours.
Yeah, and also if you...
And one case in DICs, I would like to say, patient had third cesarean section in our hospital, and then after 3 or 4 hours, she started oozing from her wound, and there was also oozing from her intracat side. So we used this recombinant factor, we gave her 3 vials, and the patient was saved.
The other important thing is that it is much cheaper to use a 2 milligram vial than 2 1 milligram vials. Because I think 1 milligram vial is around 45,000 and 2 milligram vial is around 65,000. So, yeah, but I think you need to tell the government that they will save much more money by keeping the 2 milligram. I think the minimum that we need to give is 2 milligram, and then decide whether to add 1 more milligram after 10 minutes. I think we will just finishing, so we will just go on to the Foxy focus. Foxy has got a Foxy focus, and if you look at it, essentially everywhere after uterotonics, recombinant factor 7A is now mentioned as the second step, and that is exactly what you want, what we want you to go back home with, and that is where we position recombinant factor 7A. If you look at severe PPH following delivery, it is the second step after medical and mechanical methods before going on to surgical options. Similarly with traumatic PPH, similarly with placental abnormalities, and similarly with cesarean section PPH due to atony. So mechanical methods and medical methods go on together, then is your recombinant factor 7A, and if that doesn't work, then you move on to surgical management. I think we will end with that. Thank you.
Except in cases of traumatic PPH where we have to explore and we have to give sutures also.
Yes, I think traumatic PPH essentially, obviously traumatic PPH you have to address the cause, but after traumatic PPH what happens is many patients would go into DIC, and that is where when you have the generalized oozing, that is where recombinant factor 7A comes in again before doing a hysterectomy.
Thank you so
And
much.
I would
With
like
that,
to say one thing also. The 10 patients what we lost, all were referred from periphery.
Okay, we'll take a photograph. While
yes, photograph is on the sides. We've got, yes, because it's not because of the lights. Yeah.
Thank you, and it's excellent to. Yes.
Ma'am, we have questions over a cup of tea because it's
I will take
11:30.
quickly. Yeah, madam. Is it safe in renal or disorder, Priyanka? Yes, it is.
Yes.
It is not safe to use it in renal disorder as such, but when a patient is coming to me and I am not very sure of our lab reports also, sometimes we tend to use it and later we come to know that the report was not good. But
Yeah.
in HELP cases, yeah, it's better to use it and save the patient anyways.
All right. With that, can I request the moderator and the panelists to please join us next to the backdrop? We would like to thank Novo Nordisk for this session. Thank you so much for your support. With that, can I request the chairperson to please join us on the stage? We have Dr. Meena Sawant as the chairperson, along with Dr. Supriya Jaiswal ma'am, Dr. Abha Rani Sinha, and Dr. Neelam. Can I request the chairpersons to please join us? Can I also request our first speaker, Dr. Rama Joshi, to please join us on the stage? This is all to save time. Thank you so much. With the permissions of the chairperson, can the speaker start?
There is a change in the. Just a brief introduction, though many of us know her. She's the principal director in HOD, Gynae Oncology and Robotic Surgery, FMRI, Gurgaon. And she is instrumental in initiating the DNV Super Speciality Program in India and EGOI Fellowship, leading robotic gynae oncosurgeon in the country, and associated with many societies. Welcome, ma'am. Ma'am, the floor is yours.
I with due respect, thank you.
So we welcome Dr. Rama Joshi. She is going to talk on endometrial cancer, a new era in management. So let's hear from Dr. Rama Joshi, please.
Respected chairpersons, my dear colleagues and friends, at the outset I would like to thank the organizers especially for this invitation, Dr. Vinita Singh, Dr. Amita Singh, and Dr. Monica, and the organizers. Endometrial cancer, the new era of management. Greetings from the Department of Gynae Oncology at Fortis Memorial Research Institute, Gurugram. Once we talk about endometrial cancer, I remember my days at the time when I was a student, and after that...
Can we have some silence from the photography end? Please, we need some silence.
So once we talk about the endometrial cancer, I remember my days at the time when I was a postgraduate student, and that's how I grew up as you can say, in my early academic career. It was the hysterectomy, BSO, and post-operative radiation therapy. That used to be the standard of care. But look at the scenario, how it is changing, how we are becoming more and more precise in treating our patients, and so far as the quality of life is concerned.
So majority of the patients in gynecological cancers, we are concerned not only for the survival, but along with extending the best survival to these women, the quality of life, which makes a difference. And that's how we can extend that. Along with that of the quality of life, we can extend when we go for the optimal surgical management, and also we can minimize the treatment related morbidity in selecting the adjuvant treatment of the patients and define where we can go for the radiation therapy, where we can go for the chemotherapy, and there is many more to really see what all has come onto the progress so far as the endometrial cancers are concerned. I think I'm missing number of the pictures from this. I failed to understand because when I had loaded actually my presentation, there were number of the pictures which I was able to see and I had seen finally, but that is really not shown here. So my apologies for that. And thanks to the organizers for the kind of, I think, the display management. Anyway, so gynecological cancers, definitely we are looking at with that of the, I think you have, can I make a change? There were two presentations. Have you, because the presentation, I will not be able to make it. I can give you the pen drive if you want, because this is a total blank presentation. बिल्कुल है मेरे पास. आपको मैंने बताया था आप मेरा presentation देखो. Thank you for bearing with us for the technical glitches. आप इसको ऑन करिए. पटना वाला लेके आइए. अरे रुक जाओ. हाँ या एंटर विजिट. एक मिनट. बी वाला नीचे वाला. हाँ नहीं नहीं ये नहीं है, ऊपर वाला है. ठीक है, ये आ रहा है इस पर. ये डाउनलोड क्यों नहीं हो रहा? डाउनलोड नहीं हो रहा. उस पर तो हो रहा था, आपको मैंने दिखाया था. अरे व्हाट इज दिस? हाँ हो नहीं रहा है ये. क्लिक करो. हाँ यार प्लीज इसको कर दो ना, नीचे वाले को. वो रन भी नहीं कर रहा है आपका. आई थिंक इट्स नॉट रनिंग. कैन आई गेट माई मैक और can I get my laptop and you carry on to the other talk? So I think my apologies, this system is not working probably. So just I'll get my laptop. By the time you can start with the next presentation. Thank you.
All right, we would then move to our next speaker. Can I request Dr. Alka Pandey ma'am to please join us on the stage?
So it's my pleasure to introduce Dr. Alka Pandey. She has been the professor at Saharsa Medical College and ex-professor in Patna Medical College. She has been the national corresponding editor Jogi, chairperson Practical Obstetric Committee, but the laurel, she hasn't written it in her CV, but we all know she was the vice president Foxy last year, and she has done tremendous good job. And she's also the state lead for Manyata program. She has been the joint organizing secretary 57th AICOG and organizing chairperson Boxcon 2015. We all know her as a person committed to Foxy and committed to Patna Obstetric and Gynecological Society.
Thank you, ma'am.
And she is going to talk on maternal sepsis.
Thank you, ma'am.
That is a very, very important subject. So the floor is yours.
Thank you, ma'am. Good morning, everyone. And at the very outset, I would like to thank the scientific committee, the organizing team, Dr. Meena Samat, Dr. Amita Sinha, Dr. Vinita, and the whole team for giving me this opportunity. So maternal sepsis is a life-threatening condition. It arises when the body's response to infection causes injury to its own tissues and organs. It may arise during pregnancy, childbirth, post-abortion, or the postpartum period. So what are the stages of sepsis? The first stage of sepsis is the easiest to treat but sometimes difficult to detect. The heart rate is above 90. The breathing is more than 20. And when you do the blood counts, it is the WBC count is more than 12,000 or less than 4,000 cells per cubic millimeter, and more than 10% of band cells. Stage 2 is severe sepsis. There may be changes in the mental processing or ability, a lower than normal platelet count, rapid breathing or difficulty taking deep breaths, discolored patches underneath the skin, extreme weakness throughout the extremities, bluish cyanosis around the lips and extremities, and loss of consciousness also. Stage 3 is septic shock. It may present as a severe drop in blood pressure, which can turn sepsis deadly. These drops can result in stroke, organ failure, respiratory failure, heart failure, and immediate death. Altered organ function in an acutely ill patient, such that homeostasis cannot be maintained without intervention, is multiple organ dysfunction syndrome of sepsis. Now, what are the predisposing factors? The cervicovaginal mucous membrane is damaged even in normal delivery. Uterine surface, especially the placental site, is converted into an open wound by the cleavage of the decidua during the third stage of labor. Blood clots present at the placental site are excellent media for the growth of the bacteria. Then antepartum factors: malnutrition, anemia, preterm labor, pre-labor rupture of membranes, chronic debilitating diseases, prolonged rupture of membrane more than 18 hours. Then intrapartum factors: cesarean delivery, repeated vaginal examinations, PROM more than 18 hours, dehydration and ketoacidosis, traumatic operative delivery, then hemorrhage, retained bits of placental tissue, and placenta previa. Now the causative organisms may be aerobic or anaerobic. Streptococcus hemolyticus group A, Streptococcus hemolyticus group B, Streptococcus pyogenes, E. coli, Klebsiella pseudomonas, and aerobic bacteria are Streptococcus, bacteroides, Clostridia, etc. Most of the infections in the genital tract are polymicrobial with a mixture of aerobic and anaerobic organisms. So we all know how to prevent this infection. Maintain good hand washing practices, then keep all delivery areas clean, appropriate waste collection and sharps disposal, then antibiotic prophylaxis, augment labor when rupture of membranes occur prior to the onset of labor after 34 weeks of gestation, prepare, store and sterilize delivery instruments, and maintain clean delivery kits. Now symptoms, we all know the patient has fever, then she has shivering, then there may be uterine tenderness, pulse rate is high, then foul smelling lochia. Delayed there may be sub-involution of the uterus. Now about the pathophysiology of sepsis. At the cellular level, sepsis is characterized by changes in the function of endothelial tissue, coagulation process, and blood flow. And what does this bacterial endotoxin do? There is widespread leukocyte activation, which releases massive cytokine, and as a result, there may be hypoxic respiratory failure, hemodynamic collapse causing shock. Then this may also lead to acute renal failure, DIC, and coagulopathy. So nowadays we have switched to national early warning score for screening of sepsis. Here you can see we have the variables as such as respiration rate, oxygen saturation, any supplemental oxygen, temperature, systolic blood pressure, heart rate, and level of consciousness. And each variable has been assigned 3, 2, or 1 score. So a score of less than 5 usually indicates that a patient was reasonably stable and lower risk, and that clinical management would usually be ward based, while a score of 5 or more was medium, high risk, and should trigger concern requiring a more urgent response by those with competencies in assessing and treating acutely ill patients. A score of 7 was high risk and should prompt major concern with emergency transfer to ICU. So, National Early Warning Score or Systemic Inflammatory Response Syndrome is recommended. Is recommended due to the better sensitivity Now, what are the investigations that we have to do? CBC, liver function test, kidney function test, lactate, procalcitonin, coagulation studies, urine analysis, blood gas analysis, and serum electrolytes. 2 sets of peripheral blood cultures should be taken. Cultures of urine, stool, sputum, or from any focus which is supposed to cause sepsis is taken. PCR and mass spectrometry are also very important in the diagnosis of sepsis. PCR identifies multiple pathogen DNA sequences and the resistance genes from both positive blood cultures and whole blood samples, and mass spectrophotometer can identify a wide spectrum of organisms from clinical isolates of positive cultures. Key advantages are accuracy and speed of analysis. Then biomarkers, we have many. They include white cell count, C-reactive protein, procalcitonin, and lactate. Procalcitonin is a peptide precursor of calcitonin and is widely used for differentiating bacterial versus non-bacterial infections. Presepsin has been proposed as an alternative biomarker to procalcitonin because of its higher accuracy, but it is expensive and less available. So now the lactate, which we are using frequently. A venous lactate of more than 2 millimole per liter should prompt critical care input, and a level of more than 4 millimole per liter despite IV fluid requiring the use of vasopressors should lead to the initiation of CVP and oxygen saturation monitoring. Serum levels of more than 4 millimole per liter alongside clinical evidence of septic shock are associated with mortality rates approaching 46%. In imaging, we must do chest radiography, echocardiography, CT of chest, CT of the abdomen and pelvis. Now about resuscitation and management. Maintain oxygenation and perfusion of vital organs and placenta while identifying and treating infection. Survival has been shown to be improved by using the Surviving Sepsis Campaign protocol administered in the first hour of diagnosis. Sepsis bundles are a group of interventions designed to follow the timing, sequence, and goals of individual elements of care to improve the outcome. And the key message from Saving Lives, Improving Care 2014 is timely recognition, fast administration of IV antibiotics, and quick involvement of expert senior review is essential. Within 1 hour, the sepsis 6 has to be followed. Administration of high flow oxygen, take blood culture from both aerobic and anaerobic without delay, then at least 2 sets of blood culture should be obtained, one drawn from the percutaneously and one from a vascular site, unless the device was recently inserted. Now administer broad spectrum antibiotics, fluid resuscitation, that is 30 ml per kg, crystalloid for hypotension, or if lactate is 4 millimole per liter should be administered. Serum lactate should be measured. Indwelling catheterization and hourly measurement of urine output must be done. Within 6 hours, you have to give vasopressors for hypotension that does not respond to initial fluid resuscitation to maintain the mean arterial pressure at 65 millimeter of mercury. In the event of persistent arterial hypotension, despite volume resuscitation or initial lactate 4 millimole per liter, measure CVP and SCVO2 and maintain CVP 8 to 12 millimeter of mercury and SCVO2 at 70%. SCVO2 or central venous oxygen saturation is a measurement that reflects the balance of oxygen delivery and consumption in the body, and serial lactate measurement should be done if the initial lactate was elevated. The pregnant women should be managed in the left lateral position to avoid aortocaval compression. Baseline blood tests such as CBC, coagulation profile, renal function tests, C-reactive protein should be sent, and other samples guided by clinical suspicion of the focus of infection are sent for culture. If the MRSA status is unknown, a pre-moistened nose swab should be sent for screening. Controlling the source of infection is paramount, and it may require both medical and surgical intervention. Antibiotics should be administered in the first hour of recognition. Delay is associated with a worse outcome. Doses of antibiotic in pregnancy are unchanged, and early involvement of a microbiologist is strongly recommended. The following is recommended IV antibiotic therapy when the patient is not critically ill. Amoxiclav or cefuroxime or cefotaxime may be given together with metronidazole. In penicillin allergic cases, clarithromycin or clindamycin and gentamicin should be used. When the patient is septic, piperacillin, tazobactam or meropenem or ciprofloxacin and gentamicin together with metronidazole should be given. For group A streptococcal infection, clindamycin is more effective than penicillin, and for MRSA cover, consider ticoplanin or linezolid. Antifungals are not needed empirically in sepsis. These drugs should be avoided in pregnancy and lactation unless potential benefits outweigh the risk. Surgical source of infection should be identified by ultrasound scan, CT and MRI of the abdomen and pelvis and removed. The two main types of resuscitation fluids are isotonic crystalloids and colloids. The administration of balanced crystalloids for the fluid resuscitation of septic patient is preferable for two reasons. They have an electrolyte composition closer to that of plasma, and chloride-rich solutions are associated with high risk of hyperchloremic acidosis. The SSC recommends 30 ml per kg of intravenous crystalloids within the first 3 hours. Individualized treatment targeted towards glycocalyx resuscitation according to fluid tolerance and fluid responsiveness is recommended. Fluid tolerance can be expressed as the degree to which a patient can tolerate the administration of fluids without the onset of organ dysfunction. Fluid responsiveness is commonly defined as a stroke volume increase of at least 10% following a fluid bolus of 200 to 500 ml in 10 to 15 minutes. Fluid overload can damage the glycocalyx, leading to poor clinical outcomes. So, fluid overload should not be done. The use of inotropic drugs represents one of the cornerstones of septic shock treatment, and SSC recommends an MAP target of 65 millimeter of mercury and recommends norepinephrine as the first choice drug. Early NE administration may improve the outcomes of septic patients. Early inotropic administration seems to successfully resuscitate microcirculation with consequent improvement in tissue perfusion and oxygenation. Vasopressin is the second line choice for septic shock treatment. Epinephrine should be considered as a third line treatment for septic shock. Low tidal volume ventilation, a lung protective strategy, aims to prevent ventilator associated lung injury and is associated with improved clinical outcomes. Oxygen therapy should be started at 15 liters per minute via a reservoir mask. High flow nasal cannula provides heated and humidified oxygen at high flow rates. Then low molecular weight heparin, insulin, proton pump are supportive treatment, and AKI is a common complication of septic shock, and renal replacement therapy uses various techniques such as hemodialysis, peritoneal dialysis and kidney transplantation in patients of AKI. The presence of sepsis alone is not an immediate indication for delivery. The decision to deliver the fetus should be individualized and will depend on gestational age as well as maternal and fetal condition. Delivery should be reserved for the usual obstetric indications after stabilization of the woman. Involvement of neonatologists, anesthesiologists and critical care consultants is fundamental, and corticosteroids for fetal lung maturity are not contraindicated. Neuraxial block is usually contraindicated in septic patients. Oxytocin bolus should be administered using an infusion pump over 5 minutes to avoid hemodynamic instability, and the decision to extubate or transfer to critical care is influenced by severity of sepsis and an appreciation of altered physiology of pregnancy. After operation, oxygen is recommended to meet the increased demand. Analgesia should be maintained with paracetamol and opioids, and NSAID should not be used because they are contraindicated as the septic patient has deranged renal function. Post-operative care in HDU is needed. Critically ill patients need transfer to the critical care for mechanical ventilation. The mortality rate has come down. आपका डर से नाम में का
मैं नहीं कुछ बोल पा रहा.
Among women who died from sepsis, a majority had a delay in care or in escalation of care or were started on antibiotics that provided inadequate coverage. So what is required? Effective communication, good documentation and maternal death audit. And to summarize, recognition is the key. Always maintain a high index of suspicion for sepsis. Implement a rapid bedside tool for detection of maternal deterioration. Implement sepsis bundles. Lab and radiographic studies are keys to search for etiology. Know your bugs. Choose antimicrobials tailored to the most likely diagnosis. Fluid resuscitation should be proper. Beyond the golden hour, escalation of care is critical to survival. Once the patient is stabilized, get to the source of the problem, anticipate and prevent adverse pregnancy outcomes. And thank you very much.
Thank you so much, Alkadi, for your very comprehensive view of maternal sepsis. I think 2 or 3 points that you have mentioned, that is NEUS instead of Q-SOFA score. I think that is important for early diagnosis. And the other point, serum lactate. I think all ICU and HDU settings, they should have a serum lactate measurement to guide the IV fluids and vasopressors. And removal of the source of infection, I think that is also one of the points. So a very good and a very informative talk on maternal sepsis. Thank you so much, Alkadi.
Our next speaker is Dr. Pramila Modi ma'am. Requesting Dr. Pramila Modi ma'am to please join us on the stage. Presentation live.
It is an honor to introduce Dr. Pramila Modi. She is consultant obstetrics and obstetrician and gynecologist at Modi Nursing Home, Patna. Honorary consultant Arogya Mandir Sansthan, Patna, and she was vice chairperson in 57th AICOG 2014 Patna, scientific chair in the 57th AICOG 2014 Patna, past president Patna OB-GYN Society, ISOPAP, past contributor and executive member, past chairperson in Akhil Bharatiya Marwadi Sammelan, She has a number of publications, more than 50, in both national and international journals, contributed 8 chapters in various books of Foxy and others, prepared several informative booklet, and she had got Ethicon Traveling Fellowship Foxy Award in 1977, and her field of special interests are public awareness in safe motherhood, contraception, midlife and geriatric gynecology. And she is going to speak on effect of obesity on feto-maternal health. Madam, the floor is yours.
Thank you. A very good afternoon to everyone in this hall, and I'm so happy to see 4 chairpersons. All 4 are very close to me. So the topic, as said, effect of obesity on feto-maternal health. To introduce, I'm not straight away jumping to the causes and all, but without telling what is obesity. By definition, obesity is a chronic disease that occurs when a person has excessive body fat with BMI 30 or more, which can negatively impact on health. BMI is also called Quetelet Index, which indicates the status of obesity. The term obesity was coined by Noah Biggs in 1600, and WHO recognized obesity as a disease in 1997. BMI calculation is done by a simple formula, weight in kg divided by height in meters. Obesity is classified according to BMI as class 1, class 2, class 3. One is 30 to 34.9, second is 35 to 39.5, and the third is more than 40, and the last one, super morbid obesity, is more than 50. Unfortunately, the incidence of obesity is increasing worldwide due to unhealthy diet, unhealthy lifestyle, lack of exercise, and genetic factors like gene number of 79068 is supposed to be responsible for obesity. Can you see this picture? You can see, my God, itna mota, ni moti aurat. So this is the picture of morbid obesity in pregnancy. Before I tell about other things, we should know what is metabolic syndrome. Obesity is an important aspect of metabolic syndrome which predisposes to impaired glucose metabolism, leading to type 2 diabetes mellitus, cardiovascular diseases, and hypertension. It causes insulin resistance and dyslipidemia. The consequences of obesity are many, but coming to the cardiovascular types, it is the coronary disease, hypertensive heart disease, stroke, myocardial infarction, heart failure, arrhythmias, peripheral artery disease, etc. Coming to maternal morbidity, the incidence of the complications are raised during pregnancy with obesity. To count early, so many early pregnancy loss, preterm delivery, medical and surgical complications, postpartum hemorrhage, gestational diabetes, preeclampsia, labor induction due to prolonged first stage of labor, cesarean section, shoulder dystocia, pelvic infection and wound infection, macrosomia, the typical picture you can see here. It's not a good healthy baby, it's a macrosomic baby. Macrosomia leading to obstructed labor and difficult delivery. Sleep apnea is also one of the factors. Depression and anxiety in the mother due to stillbirth and fetal anomalies. It's a fact that I would like to have some silence, please. It is a fact that obese people have short lifespan. Thus, it's a real warning signal to everyone who is obese, especially before planning for a pregnancy. Maternal mortality, what's it about? Maternal mortality is 4 times higher if the BMI is more than 30. Non-alcoholic fatty liver disease, which is called NAFLD, you might have heard, becoming very common, and it is really a troublesome disease. It is due to obesity. It is a serious disease, may lead to cirrhosis of liver in the long run. In this, there is visceral adiposity, especially fatty liver. See, what is my experience is any ultrasonography, most of the time, the ultrasonography report shows that at the end they write that there may be a hepatitis, there may be a liver disease, and it's a fatty liver. So we have to be very careful about it. In this, there is visceral adiposity, especially fatty liver. Obesity causes accumulation of fat in the liver, which is called hepatic steatosis. Now, prenatal care. Early detection and treatment of gestational diabetes, hypertension, etc. prevents complications of obesity during pregnancy. So, frequent prenatal or antenatal examinations and serial USG help in monitoring the growth and well-being of the fetus. Now, the care a woman receives during pregnancy is aimed at decreasing complications during pregnancy and improving its outcome. What are the benefits? Lowers the risk of low birth weight, premature birth, and neonatal death. Promotes mother's health and spots complications early. Ensures healthy weight gain and offers counseling too. And good prenatal care is always praiseworthy, and it is. We all do this, like prenatal visits. How many times? At what weeks? Second is prenatal testing. We are also doing this. Wholesome practices like vitamins, diet, etc., exercise must be introduced in the lifestyle. Antepartum management. For obese women, a gain of 11 to 20 pounds, that comes to approximately 5 to 9 kg, is suggested. In any case, weight reduction is the only essential requirement, but there is no specific intervention for preventing excess of weight gain. Nutritional strategy is more useful than exercise. This has to be taken into account. However, the only treatment is prevention and reduction of obesity before planning pregnancy. कहते हैं जब हाथ जल गया तो फिर क्या फ़ायदा, पहले precaution होनी चाहिए. Weight loss between pregnancies is an ideal way. Planning the pregnancy, you must advise that she should lose weight and she should become really fit. So weight loss between pregnancies is an ideal way to prevent complications. A weight loss of 5 to 7% significantly improves metabolic health. As we know, strict dieting cannot be advised during pregnancy, otherwise it may lead to deficiency of nutrients. Diet should be low in carbohydrates and sufficient in protein content. This has to be kept in mind. Intrapartum management, there is increased risk of complications and slow progress of first stage of labor. Thus, induction is more frequently required, which may fail many a times, and finally C-section is there ready. Obese women usually have cesarean section operation. Risk of endometritis, just now Alka has told about infections. So risk of endometritis, wound infection, dehiscence, and venous thrombosis can occur. Infection can be prevented by giving prophylactic higher antibiotics liberally. Putting a surgical drain helps in controlling the infection. Thromboembolic phenomena, a very difficult situation. The complications are prevented by obese women by early immobilization. Every woman should know about it, not sticking to bed. And so they have to wear compression stockings, which is also very useful. Practically, cesarean section is difficult to perform in obese women. Closure of the subcutaneous tissue is also helpful in minimizing wound infection. This is a beautiful picture which shows that the comfortable, what one has to wear to reduce the thromboembolic phenomena. Here it is written that it holds the stockings in place. The spiral you can see. There is the graduated compression is there always. It doesn't let the blood clot. Surgical incision. This is very important slide. Because of macrosomia in the fetus, surgical incision has to be long for easy delivery. There is a thought by some obstetricians that placement and type of abdominal incision should allow access to the fetus and have effect for the best wound closure, which is very necessary. These are the two pictures. They show the incisions. For this vertical incision in obese women, it is a good option to provide most directly and easily. The access should be to the fetus to take it out. Some obstetricians still prefer a low transverse abdominal incision. Anesthesia is a problem. Another thing is which is very bad during pregnancy in obese women. Delivery is by cesarean section in majority of cases, which needs safe anesthesia for both mother and fetus. Obese pregnant ladies have high anesthetic risk due to many reasons like short neck, difficult intubation, and managing the comorbidities at the simultaneous time. Such patients are real challenge to the anesthetist due to difficult intubation. Short neck is there. Danger of aspiration is very dangerous, life-threatening. However, choice of anesthesia depends upon the expert anesthetist. Coming to the bariatric surgery, the latest one. Bariatric surgery in this volume is reduced by restrictive or restrictive malabsorption methods. Bariatric surgery is not ideal treatment for obesity in pregnancy. I am also in this group only. I don't prefer. If all other non-invasive procedures fail to reduce the body fat, bariatric surgery is a viable option. The appropriate time of performing bariatric surgery is in the second trimester. I was very much surprised, why second, why not the first trimester? There is enough space. But the reason they have written that it is because the drugs used in the first trimester may cause anomalies, fetal anomalies. Thus, it must be very clear that in the second trimester, bariatric surgery for pregnancy, it is done. I welcome Dr. Shanti Roy. She has given a very good volume in a book written by her about pregnancy. Fetal and neonatal complications are there. Obesity in pregnancy has fetal and neonatal complications, but not a single unifying mechanism is responsible for adverse outcome. Increased insulin resistance, inflammation, and oxidative stress take part in early placental and fetal dysfunction. There is a high incidence of congenital anomalies. You can see the pictures. The limb reduction, this is the new one which I saw in the picture. Other things we know, orofacial defects, omphalocele, and spina bifida. Luckily, folic acid is there, so that is now much less. The story doesn't end there. Long-term effect of maternal obesity on the offspring. Children born to obese mothers generally become obese adults. Such children are vulnerable to cardiovascular diseases and metabolic syndrome. To conclude, when I see you, I started. Okay, there is rising incidence of obesity in pregnancy worldwide. That's why it's a warning that we should all be very careful and we should make the patients aware. The only treatment of obesity is to reduce the fat by any means. Obesity has ill effects on both mother and fetus, and there is a high incidence of maternal morbidity and mortality. Let us all take this seriously to make the women aware about the risk of obesity during pregnancy. Now, coming to little experience that I have. In my initial days of practice, I managed few cases of morbid obesity in pregnancy. Frankly speaking, I could not appreciate the fetal heart sound in any case by the general stethoscope that we use, or which I had for that I depended on the ultrasonography. While performing cesarean section, half of my forearm had to be introduced into the abdominal cavity to deliver. Total time for C-section was more than the normal. A little message that I would like to leave from today. I would like to give a message to all pregnant patients to be careful about health, diet, get used to regular exercise, and keep a watch on the body weight by BMI. We are also not very much used to BMI. We only take weight. We obstetricians should record BMI in all pregnant women, especially in obese, and obese women should prepare themselves by weight reduction before conceiving pregnancy. So, if I say obesity is a silent killer, let us prevent it by all means. Thank you very much.
Thank you, ma'am. That was a wonderful topic, and it's quite very important for all of us because we are going to see more and more cases of obesity. Thank you also for highlighting that it's best to start a pregnancy where the BMI is optimized before, because there are so many complications of high BMI. These days we are also seeing cases of pregnancy who've undergone bariatric surgeries. And ma'am, you beautifully covered, because we are going to face more and more such patients. So thank you, ma'am. And
thank you very much. Can I go down?
Yes, ma'am. Thank you.
Thank you so much, ma'am. Can I request Dr. Rama Joshi, ma'am, to please join us on the stage? As we know, she delivered a few slides, hoping that वहाँ से ही गाड़ी आगे बढ़े ताकि समय पे हमें oration शुरू कर सकें. We would also like to.
It's a very important topic. देर से आए मगर दुरुस्त आए.
Yes, ma'am. Yes. आ गया? Yes. It's on the screen.
Thank you so much, chairpersons and all my dear colleagues, for really bearing with this technical glitch. But I hope, So greetings from Fortis Memorial Research Institute, Gurugram, the dedicated department of gynec oncology there. So as I was already mentioning that the focus in gynecological cancer management is basically to improve the survival as well as the quality of life. And that's how we are looking at the endometrial cancer patients, because we have to make a balance, optimizing the surgical management, not to go for unnecessary extensive surgeries, but at the same time, we have to give the optimal answer so far as the management overall of these endometrial cancer patients is concerned. And also, we require to select what kind of the adjuvant treatment we are going to give so that we can really tailor so far as the morbidity of these patients is concerned. Look at the scenario of the endometrial cancer in 2023. We remember hysterectomy, BSO, and the adjuvant radiation therapy being the standard of care many years ago. And now we are concerned.
Request you to kindly maintain some silence.
How we are looking at the management of endometrial cancer is that we have to look into the focus of the not only the histopathology but also the molecular markers. This is mainly come up with in a part of, you can say, the answer, as we can understand that 80% of our patients, they have the low grade disease. They present to us in the early stage of the disease, but about 20% will have the high grade tumor, and they will have high mortality. What we think about that the low mortality in endometrial cancer patients is mainly because of the low grade of the disease, but once we are dealing with the high grade malignant situation in endometrial cancer, that is really a matter of concern for all of us because of reducing the mortality in these particular subset of the patient. That's how the focus is on. And it is, you all must be aware by now that it is TCGA molecular groups which have looked into the various molecular markers on the endometrial cancer. Why it is so? I think we all have experienced that the early endometrial cancer, stage 1A disease, endometrioid carcinoma grade 1, and you will find in no time they are presenting with that of the bony metastasis, and these patients die. It's mainly because there is something other than the histology as well as the grade of the disease which is responsible for the aggressive behavior of the disease and thus leading to the metastasis and also the increased mortality. And that is how we are becoming wiser after the molecular groups which have been defined in endometrial cancer. On the other hand, we have the molecules which are going to give rise to the better outcome even in advanced stage of the disease and in extensive stage of the endometrial cancer patients. They do good. Maybe that we are going to select, can we do something better? and reduce the adjuvant treatment or the systemic therapy in these particular patients. And that is how the FIGO staging of the endometrial cancer in 2023 has looked into the various pathological factors, histological factors, what is the tumor pattern, as well as the molecular classifications, in order to address the complexity of the endometrial cancer and its management. And looking into the FIGO 2009 to FIGO 2023, it is the integration of these molecular markers and this surgico-pathological FIGO system, which is going to modify totally the management of the endometrial cancers today. And that is how we can see that such a drastic change in the surgical staging, as you must have already seen. This includes not only the histology, it's great, and also looking into the LVSI, whether it is focal, whether it is extensive LVSI, and all the molecular markers. What is the status of the P53 MMRD, and also looking at the pole mutations. Pole mutations basically are addressing the favorable prognosis. MMRD and NSMP. NSMP means there is no specific molecular profile of the prognosis basically can be detected in these patients. This is totally a different group, and that's how we are wiser today in knowing what is the molecular markers in these patients and how we can really do the best. For example, if I give you an example of the pole mutation, if it is, you can say, the stage 1 disease, 1A, or maybe the tumor is comparatively more aggressive, but if it is pole mutant, means you can take up, the prognosis is going to be good, and you do not require to go for any adjuvant treatment. Similarly, sometimes we think that there's a low-grade endometrial cancer in stage 1A disease, but this is P53 mutant. These are the cases you have to look into more aggressiveness, and this tumor will be upstaged. So it is looking into the pathology at large of these patients so that the stage of the disease also changes. Otherwise, we would have thought of stage 1A disease, but P53 mutant will make it stage 2C disease with molecular marker P53. So that's how we are looking into the molecular profile today. And looking based on this only, the ASCO, ASTRO, and ESMP cancer guidelines have been formed, how we can treat all these patients better, optimally, where we require to give them the adjuvant systemic therapy, where we can omit the adjuvant treatment. So far as the surgery is concerned, I think all my colleagues will agree with me that today it is the minimal access surgery which is the standard of care for the endometrial cancer patients. We have become wiser in the minimal access surgery selection as well. With the advancement of the technology, and it is the robot-assisted surgery, which is actually, you can say, the advancement onto the ergonomics of the managed surgical management for the surgeon, as well as, of course, the better outcome towards the patient. We are becoming wiser in selecting our patients where we should do what should be the extent of the surgery. And that is how the studies have looked into which one is superior. And today, robotic surgery is definitely superior to the laparoscopy in terms of the intra as well as the post-operative outcomes of these patients. On the other hand, we are concerned about the oncological principles, because what we operate today, we do not know whether this is really the good technology for the patient or not. So we have to address the survival advantage and the survival comparison to that of the standard surgical arm of the open surgery. And here we could see that this oncological outcome is very similar in all the groups. So having said that, there is definitely the advantage of the minimal access surgery, which has been proved into phase 3 trials. And that's how we are becoming wiser to extend them the best way possible. Not many of the GYN oncologists had really taken up the laparoscopic surgery when it was LAP2 trial was published. But after the introduction of the robotic surgery in 2005 and approval by the FDA, within 4 years you can see that there was an 80% increase in adopting the technology of the robotic surgery for endometrial cancer patients. And that's how we can see we are facing a lot of the questions to ourselves in order to know and learn whether the extent of the lymphadenectomy as a part of surgical staging in endometrial cancer is the same for all, or are we going to optimize it based on the individualistic approach? And it is mainly because of the added morbidity of the extensive lymphadenectomy. When we see that the lymph node positivity is about, say, 10%, is it justified that we are doing the extensive lymphadenectomy up to the renal vessels in all? That is why we have become wiser now. We are selecting and we are following the sentinel node algorithm. And in order to select where we can pick up the microscopic metastasis in the nodal region by performing the sentinel node mapping, and we excise this node, and that's how you can see that the first of the node affected is the sentinel node. So if we can pick up this node, which can have the varied, you can say, the presentations, there may be lymphatics going to the 3 nodes, and there may be 2 lymphatics coming to 1 node. That's how you can pick up. And going for the ultra staging of the same, we can definitely detect and diagnose the micrometastasis in these patients. That's how we published our this paper, which basically looked into the morbid obesity and compared with that of the non-obese. I think we recently heard about the obesity, wonderful talk by Madam. And that's how we are also looking into how best we can do for these patients. This is a small video just to give you the glimpse that this is the live workshop where we did for the endometrial cancer patients. And you can see that this was the patient where we had taken up was the uterus confined disease. And we had gone for the minimal access or the robotic, rather, sentinel node mapping. And that's how we did the sentinel node mapping. But before that, algorithm requires to be followed. There were no abnormal nodes detected on the imaging, and we had to use the ICG dye. This is the small video. This is unedited, but it gives you the glimpse that how we are doing it. And it's very, very important to understand that to reach to the retroperitoneal region in order to know which one is the sentinel node. Here, the peritoneum between the round ligament, you can say, and the infundibulopelvic was open, and you could see that after injecting the dye of the ICG, we could actually locate the sentinel node. And that's how the lymphatics which cross the internal iliac and go, we have to follow them. Sometimes they can be very much parallel to that of the ureters as well, going to the periaortic node. But in this case, this is how the node could be detected. It's important for us to understand while we are doing the sentinel node excision, we do not have to damage the node itself. And we have to be very precise in the dissection of the surrounding area. Here, this was located in the obturator region. So it's important for us to understand where exactly the obturator nerve is. So surrounding dissection was done. And that's how we could go for the sentinel node excision. And this is the way we can define the sentinel node, and we can map the sentinel node as well. And following this, we had gone for the complete lymph node dissection. This is what was actually the situation after the complete pelvic node dissection. So I think in this particular era, that's how we are going for the more precision. and we are going to define how best we can do it. That is evolving the landscape of the immunotherapy in the advanced stage of the disease, which is showing the certain benefit in the number of the trials, and that's how we can conclude that we have to consider the histology and the molecular markers. Minimal access surgery is of course the standard of care, the robotic surgery being the choice of the surgical management, targeted therapy, and it is the precision medicine which is emerging. These are all my patients who are my inspirations. You can see such a morbid patients, and if I just give you the glimpse how she was walking the very next day of the surgery, and it was our entire institution was just going to say hello to her, and she was so happy and smiling, and she went home the very next day. This is my Department of Gynae Oncology and the Robotic Surgery at Fortis Memorial Research Institute, Gurugram. Thank you all for your patient hearing.
Thank you, Dr. Rama Joshi. I think hats off for your wonderful work. And thank you for telling us about the recent management of endometrial cancer, the molecular diagnosis. Definitely it helps to prognosticate the case, and on the basis of this we can decide the treatment. And of course minimal invasive surgery has benefits over open surgery, and robotic surgery is the answer for the modern management. And regarding sentinel node biopsy and sentinel node to decide for the lymphadenectomy, I think that was also a very good thing to reduce the morbidity of these patients. So ultimately what we are offering the patient is a good quality of life and a cancer-free survival. So thank you so much. It was really a very enlightening talk, and we all have been.
Yes.
Thank you so much.
Thank you so
Thank
much.
you. We come to the end of this session. Thank you, madam, for your wonderful talk. And then all the keynote speakers were excellent.
Photo.
And so, thank you very much. And all are charged for the oration now. Thank you very
Can I
much.
request the chairperson and the speakers to please join aside for the picture and the mementos? With respect to the oration, can I request Dr. Ranjana Sinha to please join us on the stage and take the proceedings further?
A very good afternoon, and we are here with Professor Anmola Sinha oration of 29th Foxconn 2024. As all of you know, Madam was a great obstetrician, and her legacy is being carried over years and years by Patna Medical College professors and all the faculty members. So, to chair this session, it is my privilege to invite Padma Shri Professor Shanti Rai Madam on stage. Madam, as all of you know, has been ex-President Bihar Obs and Gynae Society, ex-Governing Council member of ICOG, organizing chairperson 57th AICOG 2014, and currently also Madam is an epitome of elegance, punctuality, and Madam has academics in her blood. Still, Madam is writing so many books and guiding us during our conferences, and we are really fortunate to be her students. Madam, welcome to this oration. Next, we have our very senior past president of Patna Obs and Gynae Society, Dr. Kusum Gopal Kapoor Madam. We are fortunate to have Madam Kapoor here. In fact, Madam has come down from US for this conference. Madam was a past president Patna Obs and Gynae Society, ex-chairperson Rural Obstetric Committee of FOGSI, and patron and founder member of Patna Menopause Society. Welcome, Madam. Next, I would like to invite Dr. Alka Pandey Madam, past president Patna Obs and Gynae Society, ex-professor and HOD Department of OBG Lord Buddha Koshi Medical College Saharsa, and Madam has been ex-vice president FOGSI Madam, welcome to this session. And finally, a very illustrious daughter to and finally, a very illustrious daughter of a great obstetrician on whose name this oration goes. That is Dr. Geeta Sinha, Head of the Department of Obs and Gynae, Patna Medical College, Patna. Madam is a very active member of Patna Obstetric and Gynecological Society, and Madam is a great clinician and an academician par excellence. So I welcome all the chairpersons to this session, and I request Madam Shanti Roy to kindly tell us about Dr. Anmola Sinha, Madam, her life history, please.
Thank you very much for giving me this opportunity to say something about our great teacher, Professor Anmola Sinha. At the outset, I will say that she was a combination of beauty and brain. She was equally beautiful as well as intelligent and very brilliant. She had excellent academic careers. Now to most of
I
you must
request
be
our
knowing-
audience to please maintain silence, please.
Many of you might be knowing about Professor Anmola Sinha, but for those who do not know about her, I will be briefing a brief history of her life. She was born in a village called Shahi Minapur of Muzaffarpur district in a farmer's family on 9th April 1929. She had a fiery zeal to become a doctor from her very early childhood. She was married in 1943, and only after that she could pursue her studies, because at her own farmer's family no one was educated and they didn't realize the importance of education. Now after marriage she pursued her studies first in Bankipur Girls' School, Patna, and then in Patna Science College. All along her career at she had a brilliant career all along her studies. In 1954, she passed MBBS from Prince of Wales Medical College, Patna, with honors and gold medal in pathology and surgery. Just 2 years later, she got MS in obstetrics and gynecology, which was a record-breaking achievement because nobody passed it so early after MBBS, and it took 3, 4, 5 years to complete the MS course. But she did it in only 2 years. She did her MRCOG from Royal College of London in 1963 and FRCOG in 1976. Throughout her whole academic career, she was a scholarship holder, and including her overseas pursuit also. She was so intelligent, so brilliant, that she was always awarded with scholarships. Since her graduation in 1954 till superannuation in 1987, she worked in Patna Medical College and retired from there. Please be silent. Please be silent. Please don't talk. And retired from there as the head of the department. During her tenure, she introduced many new initiatives in the Patna Medical College, as regular seminars for PGs, audiovisual techniques for teaching, pap smear examination. She was also the principal investigator for ICMR projects, which were highly appreciated. And as a result, Patna Medical College was selected as the center of human reproduction later. She was par excellence vaginal surgeon, and her clampless hysterectomy and mini Manchester repairs with minimal or no cervical amputation and repair of flaps with precision are still remembered who have seen it. She was one of the first few gynecologists in India to recognize the association of thrombophilia with recurrent pregnancy loss and the role of heparin in its treatment. She was president of Bihar Obstetrics Gynae Society in the year 1984 to 86, and to encourage the youngsters in society, she started Professor M.P. John and Professor S.N. Upadhyay gold medals for best papers in the subjects of obstetrics and gynecology. She was offered a very prestigious post of President of India nominee for Banaras Hindu University as head of expert committee for appointment of teaching faculty from 1990 to 1998. Free Thinker Association honored her twice with Lifetime Achievement Award for her invaluable contributions to the society. With these few words, in brief, I have told you in brief about Professor Anmola Sinha, and we all have great regards for her. Even today, everyone remembers whoever has seen her or has seen her working. Now I hand over the mic. I am very happy that Dr. Jaideep Malhotra has come here to give the oration in her memorial. Dr. Jaideep Malhotra will be introduced by Dr. Alka Pandey.
May I request Dr. Jaideep Malhotra ma'am to kindly come and take a seat on the dais, please.
Respected orator, Madam Jaideep Malhotra, Madam Shantri Rai, Dr. Manju Gita Mishra, my friend Dr. Pramila Modi, and all intellectuals, delegates, Dr. Alka Pandey and Dr. Geeta Sinha, and of course the President of the Society, Dr. Meena Samant. सब्जेक्ट जो डॉक्टर जयदीप मल्होत्रा ने चुना है, अद्भुत मातृत्व, ये सब्जेक्ट मैडम के लिए बहुत ही अप्रोप्रिएट सब्जेक्ट है, क्योंकि शी यूज्ड टू टीच obstetrics very nicely and she used to love every student who worked under her. So this was the great criteria of Madam Anmola Sinha. Now this subject Adbhut Matritva is really Adbhut because it is a God gift to every mother, every woman, and but motherhood has 4 important pillars, that is family planning, antenatal, natal, postnatal and child care. So all these pillars should be safe, and it is the duty of all obstetricians to make it safe. Certain complications may occur in this journey. Although this journey is very pleasant, but certain complications may occur. For example, sepsis, hypertension, obstetric hemorrhage, and beside that there may be thrombosis and cardiac diseases. So and anemia, of course, anemia. So all these should be tackled nicely by all obstetricians, and then it will become really adbhut, wonderful matritva. Matritva is actually love and care of mother to her child. So thank you very much. Now I hand over the mic to Dr. Alka Pandey, who will introduce Madam Jaideep Malhotra.
Thank you. Thank you, ma'am. So, Dr. Jaideep Malhotra is going to give the oration on Adbhut Matritva, She is the Managing Director of ART Rainbow IVF, Chair FIGO REI Committee, Member of Accountability Group of PMNCH WHO, Vice President INSARG, Past President Foxy, ISAR, Aspire, IMS, SAFORMS, ISPAT, Editor-in-Chief, SAFOG and SAFORMS, Regional Director, South Asia and Donald School of Ultrasound, Professor Dubrovnik, International University, Croatia, Past Secretary and Vice Chairperson, ICOG. She has initiated many new things: Club 35 Plus, Rotary Club of Agra Grace, Adbhut Matrutva, iMums app, and she is credited with first 500 IVF babies of Nepal. She is advisor to Maulana Azad Medical College, New Delhi, JNMCH Aligarh, SMS Medical College, Jaipur, and more than 500 awards from national and international organizations. And to name a few, she is recipient of honorary FRCOG and FRCPI, recipient of Nepal Samman Award, then Forbes Most Successful Women, then Economic Times Most Inspiring Woman Award, Foxy Dr. DC Datta Best Textbook Publication Award, and many more. So, Madam.
May I request Dr. Geeta Sinha, Madam, to speak about the topic, and Madam.
Dr. Jaideep Malhotra is a very charismatic and dynamic personality, and we all know her so well. And she will deliver a wonderful oration on Adbhut Matritva. And I just wanted to speak a couple of lines about my mother, Dr. Anmola Sinha. She was one of the first few girls of Bihar, probably the first lot who dreamt of becoming a doctor and who studied and joined Patna Medical College. And in fact, she came from a village where the village folks had such a weird mentality that nobody was interested in girl education, and they also strongly believed that whichever father thought of educating his girl child died. And it was that kind of a situation. And so it was like swimming against the tide. And her education was only possible by marrying a most unique and a great gentleman with a great and a different ideology who was interested in women education and women empowerment. And that was my father, Mr. Kamleshwar Prasad Sinha. And he was the one who funded her education by doing extra tuitions. He also came from a very poor family. So by doing an extra tuition in Zamindar families, he funded her education till her scholarships made her self-sufficient. Thank you.
Can I? Thank you so much, chairpersons, very, very esteemed and very prestigious and very close to my heart. And each and every one of you from Patna Obs and Gynec Society. Thank you, Meena. Thank you, Amita. And Vinita, I'm missing her. It's always been a pleasure, because whenever I have come here, it's been very, very enlightening, and the kind of warmth and love which all of you bestow is something which I'll come running any time. Thank you so much for having me for this very, very prestigious oration. You've heard a lot about Dr. Anmola Sinha, and my real tributes to such a great human being, because it's really important that we must remember that no one is born a change maker. It is something you become when you see a problem and then you dare to become part of the solution. So I feel today this oration is going to help a lot of us become a part of solution and not a part of the problem. As we understand today, I mean, a lot can be said about a mother, but I would only say that a mother is a family's richest possession, a being of priceless worth. But how many of us really do realize this? And that's why this presentation actually has been prepared for people who are motivated enough, to take care of our mothers, who also know that a little time which they spend with our patients are really going to change their lives, and not only their lives, but the lives of their children and the future generations. Plus, along with that, it's also very important for us to understand that it's not only that we are changing our lives, but we are helping our nation also in a big way. Because the kind of, the budgets which we have for health are not really enough. So prevention is also something which is very, very important. Now, I've been hearing a lot that India has really done the undoable. We have decreased the maternal mortality by leaps and bounds and exponential, but of course we are still nowhere where the SDG goal is there. And of course there are a lot of differences between the states also, and those are some things which we have to really understand. And let's really face the facts that today we have almost about 130 million births globally. Now when you look at the picture, 56 million have maternal anemia, almost half of them. 42 million have maternal obesity, 26 million have malnutrition, and about 21 million have maternal hyperglycemia, and about 8 million have hypertension. And what we have to understand here is that not only do these conditions increase the risk of adverse outcomes in a pregnancy, they increase the perinatal mortality and the morbidity, but we also identify both mother and offsprings who are going to be at a high risk of future diabetes, obesity, hypertension, cardiovascular disease, strokes, and many more things. Similarly, as the maternal mortality, we have reduced the infant mortality also. But even today, we are losing many more children, probably the maximum in the world in the under 5 age group. And again, nutrition is something which plays a big, big role. And this is in spite that we have reduced our infant mortality. But under 5 is still not really reduced. Now, we do understand, and I'm sure each one is aware of, we in India, or maybe I can tell you the region, we are the obesity capital of the world. We are the diabetic capital of the world. By 2025, the number which we had of almost about 72 million in 2017 diabetics, we are going to double that. I don't know whether you know this or no, but India and China have the same population. We have the same number of births, but you will be shocked to know that in our country, we have 3 times more preterm birth than China. Now, all this little information is important as we proceed further. And if you're seeing every day, you must be reading in the newspapers, so and so succumbed to cardiovascular accident. Now, normally these accidents or NCDs or non-communicable problems happen later than the 5th decade. 55 is an average age in the world. In our country, it happens 10 years earlier. 45 is the age. Now, please just listen to each and every word, because it's really important for you to understand, because you're going to be the change maker for tomorrow. Every household has cancer, but which cancers are being reduced? But the lifestyle associated malignancies are on the rise. What is this lifestyle which we are talking about? We've had a lovely talk by Dr. Pramila Modi on obesity. Similarly, the congenital abnormalities. Of course, with age also they increase, and of course the environment and other things are also big contributors which we must definitely pay heed to. Now, when we used to talk about nutritional deficiencies when we were young, folic acid and iodine were the ones which used to actually come in our minds. But today iron deficiency, iodine deficiency, calcium deficiency, and vitamin D deficiencies are also major contributors, apart from the other malnutrition which is there. And I can tell you right away, none of you have the right kind of nutritional status if we may just check, including me. So it is a huge, huge lacunae which needs to be really filled up. Now, how does this have an effect on all of us? I'll give you a small story of a study which was held a few years back in a very small village in Gambia. So what did they do? They just checked all the mothers and the children, and the mothers who were getting pregnant in the harvest season or in the drought season, because Africa has very extreme weathers. And what they found out was that the methylation patterns of all these children in the two different seasons were absolutely different. And their immune status was also very much different. Now imagine what a seasonal change can actually do. Now, if you've heard of Audrey Hepburn, a beautiful actress in the West, but not many of us know that she was born during the famous Dutch hunger winter, which was in the 1940s, in 1944 to be exact. And all of us know as a very beautiful actress, but we don't know that she suffered from anemia throughout her life, from the respiratory illness, and also clinical depression. And this is something which she really actually succumbed to, because all these factors were very common in the population at that point of time who were exposed to that Dutch hunger winter in the 1940s. And what was seen later on in that population was that there were many people who had history of breast cancer and the cardiovascular disease. And mostly also what was important at that point of time was that if women were exposed in the preconception period, they had infertility. If they were exposed in the first trimester, a lot of them had obesity and heart disease. Second trimester, airway disease and diabetes. Third trimester, diabetes and insulin resistance. So you can imagine what happened. Now, a lot of us understand, and we always say, oh, this has come from my mother or my father, and genes is something which does all the problems. Now, there's a very famous song which I've put here from Paul McCartney, which actually says, though it takes a lot of power to make a big tree grow, it doesn't need a pot of knowledge, because a seed knows what a seed must know. Meaning, like in the seed, all the genetics is there, and it will grow as a big tree wherever you plant. And if you and I understand, it's not going to happen the same way, because the same seed, when you throw in at different situations, is going to grow very, very differently according to the environmental circumstances. And it's not only the genetics which is there, the epigenetics is also equally important. So we definitely inherit much more than our genes, and that's something which we need to understand. And epigenetics is something which is actually modulated by the environmental factors and our lifestyle and many other modifications. So this brings me to ask you, how many of you actually have read any one of these books which actually tell us that the fetal origin of adult diseases, lot of foundation of the diseases which we are going to have in our adulthood, the foundation is laid in the mother's womb itself. So today we do understand genetics, but today what we understand is that epigenetics also plays a very, very important role, and it is only through epigenetics that environmental factors like your diet, your stress factors, or the prenatal nutrition, or the prenatal stress, or the postnatal behavior can actually leave a long and large imprint on our generations to come. And I'm not talking about one generation, I'm talking about next 3 generations. Whatever happens to us today will actually affect next 3 generations, and these are transgenerational. So fetal programming hypothesis is a real one. And today we do understand that there's a lot of evidence available which will actually tell you that there is definitely something which is called as early developmental influence, which will lead to a lot of non-communicable diseases in the times to come. Which one of these mice is a healthy one? Now if I ask you this, you will say the one with a very nice golden coat. But if I tell you the one at that end is the one where a proper DNA methylation has happened, and this is the one which is lesser prone to diabetes and cancer, because the methylation of this particular mice has been really good. So DNA methylation also has a lot of effect on, and it's also controlled by a lot of epigenetic mechanism. Now this has a lot of links between a lot of diseases which we have, whether it's malignancies, muscular dystrophy, diabetes, hypertension, obesity, cardiovascular disease, and so on. Now I'm sure all of us are drinking this water from this bottle. Now if I tell you that a lot of things which we are using every day, which are avoidable also, and which probably will change a lot of problems which are going to come to us. Environmental contaminants, plasticizers, the toys with which children play, the cosmetics which we use, the preservatives which we add in our food, or the canned foods which we use, the sanitizers which we use, and the air pollution. So Archana was just asking me, obesity is a common problem. I said, yeah, some of it is our fault, but some of it is not our fault. Maybe this is our fault also, and maybe this is not our fault, because all of them are obesogens, all of them are diabetogens, all of them disrupt the thyroid and the neurodevelopment and the reproductive disruptors, and their fertility disruptors too. And can you believe all of us are contaminated with these, but what is more problematic is that our children are being born pre-polluted. So these contaminants are found in the newborns and in utero. And all these endocrine disruptors actually harm us at every stage of life, whether it's intrauterine, puberty, or our adult life. Now, can we really avoid? That's again the next question I would ask. The undernutrition, the overweight, obesity, hypertension, and hyperglycemia, we need to really understand again, because if you see undernutrition, the fetal undernutrition, now whenever there is, the nutrient demand exceeds the supply, all the functions of our system, whether it is the liver, blood vessels, kidney, pancreas, go haywire. And the cumulative effect is going to be that we will have hyperlipidemia, we will have central obesity, and we'll also have insulin resistance. And insulin resistance is one of the major key players in a lot of issues which we suffer later on. So there is a dual teratogenicity. We have a nutrient mediated teratogenicity with undernutrition, and we also have a fuel mediated teratogenicity with overnutrition. So both are actually really harmful. Now whatever I have said, let's connect the dots, because this is something which I feel most of us don't pay attention to. So if somebody has an elevated blood pressure during pregnancy, regardless of the type of blood pressure, can you understand that this particular lady has higher risk of later cardiovascular disease and cerebrovascular disease and kidney disease? Can you just now understand, because pregnancy is one of the times where the people who suffer will have long-term impacts. So hypertension has this issue. Now, if somebody has gestational diabetes, now again, there is a heightened risk of developing cardiovascular disease in the mothers and the offsprings who suffer from GDM. And of course, majority of them will land up into a type 2 diabetes in the next 5 years. So we have to understand again. Now, we are the preterm birth capital of the world. Has anybody ever thought that those children who are born preterm will have much more, and it's a risk which is non-modifiable, of cardiovascular disease which is incurred at birth itself. Now, a lot of times we do unnecessary, very fast cesarean sections at 32 weeks, 33 weeks because of high-risk pregnancies. Please pay a thought whenever we are doing all that. Now, a lot of the medical aspects are there, but have we really thought about the mental health of these women who are going through? Because the mental health of the woman itself will play a lot of role on the personality development of the child. A child hears almost about 5,000 words from 20 weeks onwards. And the neurocognition, the understanding, the relationships, and the, I'm getting disturbed, please. So it all has an effect on the child because of the perinatal mental health of the mother. So there is a huge association between the perinatal mental health, pregnancy and neonatal complications. And we must understand that perinatal mood and anxiety disorders are associated with higher risk of maternal morbidity, hypertensive disorders, cesarean section. Severe mental illnesses are also associated with low birth weight, hypertensive disorders in pregnancy and cesarean section. And of course, mental disease of pregnancy again has much higher and severe maternal mortality and morbidity and preterm birth. So dear friends, can we really change? If we provide a very good antenatal care, can we change the outcome of these pregnancies is the next question I would ask. And if you tell me yes, I would say you are very wrong, because even early antenatal care is actually too late to prevent majority of the birth defects, which are very critically, in this period. The heart begins to beat on day 22 of conception. The neural tube actually closes by day 28. The palate fuses by day 56. It's too late to prevent any implantation errors and also to restore allostasis. So it is very, very important for us to understand that preconception care is the one which will probably have the maximum outcome on the time and the care which you invest in people, and that's where the preconception care is, then pre-implantation, then first trimester, and then late pregnancy. Now, pre and periconceptional influence actually affects the organization of our DNA, our epigenome, the mitochondria, the metabolism, placentation, and many other things. Now, so is pre-conception or pre-pregnancy BMI important? Now, as we have already understood, whether it is low BMI or it is high BMI, both are related with many, many complications, which I'm not going to go into the details, but I'll show you just one picture. If you'll see here, it should stay in our minds. Now, this is an egg. Now, this egg, if you see here, if you increase the dietary fat intake of the mother who is in the preconception stage, look at the fat droplets in the oocyte itself, the increase in this. Look at the mitochondria. The lipids and the sugar alter the mitochondrial activity, and also the micronutrients in the DNA actually modify the DNA itself. So that egg is present in the fetus of the mother who's carrying. So the second generation is already affected, and it may be much, much more. Similarly, diet, also if you see, this is the mitochondrial stain of a normal diet patient in the egg, and this is what the mitochondria looks like. And mitochondria are the source of energy and will dictate a lot of things which will happen to us. Now, let's not blame the mother also, because fathers also have a little small contribution. It has been seen, even fathers who are obese or who are diabetic or who have impaired glucose tolerance, they also add on fuel to the fire which we are really burning in. Now, I think we have now understood that periconceptual medicine is the new era, and we have also understood that whatever happens or whatever we need to do is in the pre-pregnant stage, and then follow it up with a good pregnancy care to prevent the disease and the disability in the times to come. So what is it that is really going to have an effect? Minus 12 weeks before pregnancy to about plus 8 weeks at pregnancy is the most happening period. So if we optimize all the parameters at this point of time, I think we'll improve the outcomes of not only pregnancy and children, but our future generations. Now, we as gynecologists and obstetricians are very privileged, because we meet the patient at least 9-10 times in that 9 months when she is pregnant. And there are many things which we can offer to her during that period. So even one small information every time can change the way she looks at herself and her family and her future generations, and this probably will have a much larger impact in the times to come as far as NCDs are concerned. I don't think I have told you anything new, but this is something which all of you have known all your lives. But only I will tell you something, that knowing is not enough. We must apply it. Willing is not enough. We must do it. And that's exactly what I expect each and every one to go back and do. Because today we know this pyramid of care we have inverted. We used to feel that the last time of the pregnancy is the one where you can make the maximum changes, but we have inverted it. And we know, initially we said, okay, the first trimester is the one which is very important. But today we have a penthouse to this pyramid and we have a basement. Now the penthouse is a pre-pregnancy evaluation and care, which is very, very important. And the basement is the post-pregnancy evaluation. So if somebody has not been able to do it in the first pregnancy, at least that has given us an opportunity to modify the factors for the second pregnancy. So small opportunities are often the beginning of great achievements in the times to come, and that is exactly we should not be losing these opportunities, because I believe we are all good doctors. And who are good doctors? Good doctors are the ones who bridge the gap between science and spirituality, who observe, who record, who tabulate, who communicate, and they use their five senses. They are not robots. They are sensitive to the patient. They are sensitive to the situations which they are, and they learn, they see, they modify, and then they try to heal the person as a whole, and not only look at the fundal length, height, then fetal heart, and write a prescription. So we have to be very good doctors, because we have actually learned from the past and we are researching at present to predict our future, which is very, very important. So what is important for us? To not only focus on our short term, but also look at long term benefits. And our goals should be to optimize preconception health, give a very focused antenatal care. It has to be holistic, it has to be respectful. Now, respectful maternity care is something which is very, very important for us. It helps people to be prepared for birth and complications. The effective communication is very, very important. And when we do all this, we are definitely going to reduce the non-communicable diseases and make a very, very positive experience in the times to come, because experience really matters. You may do a very successful job, but if the patient and the family is not happy, you haven't done really anything. So focus on the preconception care. I'm not going to go into the details because of the paucity of time, but very few small things. First trimester screening, a combined test. Along with that, if we just do mean arterial blood pressure, we are going to actually predict PIH. If we do cervical length, we will pick up cases who are going to be, liable to have preterm labor. If we do integrated screening strategies, we will pick up many more congenital or chromosomal aneuploidies in the times to come. If we do a universal screening for DIPSI, we will pick up many more gestational diabetes, or we'll prevent a lot of them. And if we do a second trimester screening for anomaly scan, of course, a lot will be prevented. But I would not stop here, because what is important here and what is lacking in our care is the newborn screening. Because the newborn screening also, if you'll understand, is a big addition to the problems, especially, when we have this congenital hypothyroidism, we have cystic fibrosis, we have sickle cell disease, and many of these inherited metabolic disorders which are there, which will be picked up in the newborn period, and they will help us, give a better outcome. So are we really ready to do it, is my next question to you. Because I understand that all of us have been really, not all, but most of us have been fed up of all the stresses we've had. And quite a few of us have lost our focus and motivation, which actually made us take the specialty. Today, not many people want to do OBGYN. And that's again a very important. So what we really need is we need to use, practical skills and the latest understanding and evidence and bring back all the change makers back into our fold so that today we can make a real brave new world. How many of you have read this book? It was written way back in 1932 by Aldous Huxley. And you know what Huxley said? He actually proposed that there will be a time which will come where we will produce the kind of children we want. So if we want chemical engineers, we are going to treat them to certain portions. If we are wanting astronomers or astronauts, we will put them in the anti-gravity boxes and so on. It was very, it was a fiction, but most of it is coming true now. And I would take you back to what he said and what our Garbh Sanskar says. Because today, there is a lot of science which we understand behind Garbh Sanskar. Yoga went out of our country, came back to us, and we accepted it. And I would say the same is happening because we understand the fetal origin of adult diseases, but we refuse to understand the science behind Garbh Sanskar. And Garbh Sanskar is something which actually means that you're educating the mind in utero. I can tell you many stories, I won't. Everyone knows about Abhimanyu and many other. But what it means is that the mental and the behavioral development of the child, all foundation is laid in utero. So it's not only the disease, but also our personality which is laid in utero, and that is something which we must understand. And that brings me to Adbhut Matritva. So Adbhut Matritva project is an amalgamation of Garbh Sanskar and fetal origin of adult diseases, and both are very, very important. So there are about 9 pillars of Adbhut Matritva concept. Most of you know about it. Preconception care, then we have diet and nutrition, yoga, exercise, music, meditation, antenatal care, cosmetic care, bonding with the baby. Now bonding with the baby and the doctor are very, very important, and bonding of the baby with the parents is also very important. Birth preparedness, immunization, and postpartum care. These are the 9 pillars, and if we are able to take care of them, we are going to take care of all the future problems which our generations or future generations will actually face. Just give you a very small example. This is just one study which says that women who are exposed to selected aspects of Garbh Sanskar and of course yoga and meditation have much reduced stress, and they improve, the coping strategies are much, much more improved. Now again, very important, because a lot of women are very, very panicky and their emotional well-being is not at all up to the mark. So if they just practice these emotional well-being practices, they're going to be much, much better. And I don't think whatever I have said it in this half an hour, we can tell our patient, every patient. So that is where the birth of this app came in, because I tried many things. We started with clubs. I made film. I'll show you a little part of that film. And then ultimately we decided we can't reach out. And today I feel very, very proud, because this app, which is called as iMoms, Incredible Moms, it's not only pregnancy and care. Okay. So that's okay. So it's not only about the pregnancy care, but it starts with preconception, pregnancy care, parenting, and also postpartum care. And we had a publication also recently in the SEPHOC journal, which won the best paper prize. And what I wanted to show you was that the numbers at that point of time in 22 were small, but whoever participated in this program actually had the mean gestational age was much higher than the control group, 36 versus 38.5. The birth weight was also better. The preterm delivery rate was like, if in the control group was 32%, in this group was only 12%, and almost about 55% of them delivered vaginally, because they were mentally prepared for vaginal delivery. And along with that, the psychological scales were much, much better in these patients. And I'm very happy to tell you that today we have about 1.2 million women who are logged on to us in the pregnancy care or the womb care program. We were on the Shark Tanks. They wanted to invest in us. And we've just very recently started Beej Sanskar, which is the preconception care part. So whatever we learn should have an impact on the society at large. And that is where our use is going to be. But I can tell you again and again, we can't do it alone. And I have to compliment Dr. Jaideep Tank here to start this project Adhuna. Now, what is Adhuna about? It's that you can't do it alone. We need good staff, we need good training, we need good supplies, we need good equipment, infrastructure, supervision, monitoring and auditing. Whatever we are doing, we must audit whether we are doing the right way. We must connect with the public. We must, connect with each other and then try and make it as feasible as possible. And that is how exactly we started in 2018. And I'm very happy that Foxy is adding on many pillars to this program and going ahead. This is the film which we made. This is available on the YouTube. The audio is not playing, Bhaiya. So this is, you can actually put it in your clinics, in the waiting areas. People can actually see and understand what I
Out of all the roles a woman plays, a mother's role is the toughest. आपको कई बार ऐसा लगता है कि आप कुछ गलत कर रहे हो, पर अगर ये ख्याल आपके दिमाग में हमेशा रहे तो उन दिनों राहुल की इतनी
I'm just going to move forward. Similarly, policies are very important. So connecting with the government also is important, and during my period I was very lucky to connect with the health minister at that time, and the PM SMA actually has integrated a lot of these aspects into their program. Lastly, what are the outcomes? Making motherhood is a very blissful experience, and that is our job. Bonding of the mother and the father with the baby, very, very important for the growth and the cognition of the baby. Bonding of the couple with the doctor in the hospital, very important for a good positive experience and also for reducing the cesarean section rate. Allaying the fears of vaginal delivery, sensitizing many important aspects of pregnancy and postpartum period, and of course, if we do all this, we are definitely going to build up a very healthy future generation.
माताओं से बात कर रहा हूं मैं, आप लोगों से। पता नहीं आपकी सारी आकांक्षाएं पूरी हुई हैं, नहीं हुई हैं। एक आकांक्षा है, एक चीज है, वो आज भी कर सकती हैं आप, अगर आप चाहें तो। बड़ा आभारी रहूंगा मैं, ये राष्ट्र बहुत आभारी रहेगा अगर आप वो काम कर दें तो। आप जीजाबाई बन जाइए, शिवाजी इस देश में आ जाएंगे। आप प्रभावती बोस बन जाइए, सुभाष चंद्र बोस इस देश में आ जाएंगे। आप जयवंता बाई बन जाइए, महाराणा प्रताप इस देश में आ जाएंगे। आप विद्यावती बन जाइए, भगत सिंह इस देश में आ जाएंगे। आप जगरानी देवी बन जाइए, चंद्रशेखर आजाद इस देश में आ जाएंगे। आप लाडवा देवी बन जाइए, सरदार वल्लभ भाई पटेल इस देश में आ जाएंगे। महिलाओं, माताओं, आपका सामर्थ्य तो अनंत है। आप अपने सामर्थ्य का बोध कीजिए, unnecessary comparison मत कीजिए। Someone was telling woman can do like what man can do. Come on man, कुछ कर ही नहीं सकता जो आप कर सकते हो। Show me a place where there are great mothers and I'll show you a great nation. That's too great a job. Don't undermine it. And please become great mothers. ये तो साधारण सा काम है यार। माता को आज वही कह रहा है, नैरेटिव फैल रहे हैं। तो क्या करेगी? बच्चे पैदा करेगी क्या? बच्चे पालेगी क्या? और कुछ नहीं करेगी क्या? अरे मातृत्व का अपमान कर रहा है नैरेटिव मॉडर्न। आपको जो बनना है बनिए, मां तो बनिए ना।
So this video has come to me courtesy Dr. Archana Verma. I have to thank her. Was very, very appropriate. So lastly, I would say, if the maternal and child nutrition and stressors can be optimized, the benefits which we will accrue and extend our generations, it's going to be over generations, which is why we must all work together to seize this opportunity right now. Thank you so much for having me, and keep on lighting as many lamps as you can. Thank you.
Thank you very much, Dr. Jaideep Malhotra. You have elaborated very nicely to all problems of motherhood, and you have made aware to all delegates what Foxy is doing for that. And actually, this motherhood is a very nice journey, and you have said all about and how we will prevent complications so that the journey will become very pleasant. So thank you very much. Thank you, Dr. Jaideep.
Thank you so much.
Yeah, it was so brilliant and so futuristic, and it's all doable. We just have to think that way.
Exactly.
And plus, you have enlightened our Garbh Sanskar and Garbh Samvad. All of it has been there in our scriptures and Vedas, and we are just unaware of it.
After this Adbhut oration, I would say, we would like to felicitate our orator, Madam Jaideep Malhotra. May I request our chairpersons, Dr. Shanti Roy Madam has just left, Dr. Kusum Gopal Kapoor Ma'am. May I request Dr. Meena Samant, organizing chair, to kindly come on the dais. Dr. Alka Pandey Ma'am, Dr. Geeta Sinha Ma'am, Dr. Amita Sinha, and Dr. Anjana Sinha Ma'am, and Monica from scientific team, Dr. Monica Anand. Kindly come and join.
So, a 29th BoxCon 2024 Dr. Anmola Sinha oration presented to Dr. Jaideep Malhotra, past President Foxy, on this day of 14 December 2024 from Team 29th BoxCon 2024, Obstetrics and Gynae Society, 13th, 14th and 15th December, Patna.
Thank you so much. With that, we come to the end of the oration. But just to let everybody know, the lunch is being served on the second floor. For the senior citizens and for the faculty, we have the lunch served on this floor itself, right at the end. Thank you so much. We shall be getting started at 1:30 with the post-lunch sessions. Thank you.